Welcome to the Heart, Chapter 20. We're going to start off with just going over the learning objectives and then some really basic stuff, and then we'll get into, as we proceed, some of the stuff that you'll see won't be as intuitive. It'll just be a little bit more complicated as we proceed through the lecture. So learning outcomes are going to start on this slide, and then we have a few more after this. So it's describe the anatomy of the heart, including vascular supply and pericardium structure, and trace the flow of blood through the heart, identifying the major blood vessels, chambers, and heart valves. So, as you know, the anatomy portion of the course is mostly going to be provided by the laboratories that we have. In this case, mostly virtual labs. So, because in order for me to discuss the function of the heart, I still have to discuss the structure or the anatomy in these lectures as well. So you're going to get a lot of anatomy in these lectures, but then supplemented with more detail in your lab exercises. Then explain the events of an action potential in cardiac muscle, indicate the importance of calcium ions to the contractile process, describe the conducting system of the heart, and identify the electrical events associated with a normal electrocardiogram. I'm not going to have too much on EKGs because pharmacists aren't expected to really be able to look at an EKG in depth and diagnose a patient, but there are certain things in the EKG that a pharmacist should be aware of, and that's primarily the QT interval and a couple of other things that would be affected by medications. Explain the events of the cardiac cycle. I actually think this is really fun for me. It's interesting. It's really about plumbing and what the valves are doing during different steps in the cardiac cycle. So when the atria are contracting, when the ventricles are contracting, when they're relaxing, what valves are open, what valves are closed. And most of you have probably not done a lot of plumbing, but in my middle age at this point, I have done a lot of plumbing in my house, and you would be amazed at how similar these valves are to what is out there, that they use in plumbing, and actually they have artificial heart valves that function just like valves that you'll see in plumbing situations. So it's really, that's what the cardiovascular system is about. It's about pressure gradients, one-way valves, and things like that. So it's kind of interesting. So define cardiac output and describe the factors that influence heart rate and stroke volume, and explain how adjustments in stroke volume and cardiac output are coordinated at different levels of physical activity. So what does exercise do, and what do you see at rest, and how does the nervous system control the heart in those different situations? So basic introduction to the cardiovascular system. I already want to apologize up front if some of you are very familiar with this, depending on what you took in the past in your education, either in high school or another university. So the pulmonary circuit is a shorter circuit, so you can look here and see the pulmonary circuit is just going to go just to the lungs and then back to the heart. The systemic circuit actually goes, they don't really show a lot of detail here, but that goes everywhere. It goes up to the head and neck, the arms, all the visceral organs like the stomach, everything really other than the lungs, right? So it's going down to the lower limbs. That would be the systemic circuit. The systemic circuit is a lot longer and develops a lot more pressure. The pulmonary circuit is a lot shorter, and there's a much lower pressure in the pulmonary circuit. Now, it's a little hard to see here because they chose to use a very faint blue and then a not so dark blue. So we have the kind of the lighter, slightly lighter colored blue and red would be the pulmonary circuit, which you could see easily the shape of the lungs here. And then the darker ones would be the systemic circuit. So obviously the pulmonary circuit carries blood to and from gas exchange surfaces of the lungs. The primary purpose is to absorb oxygen and remove CO2, right? Through exhalation, you're going to remove that CO2. The systemic circuit carries blood to and from the rest of the body. Blood alternates between the pulmonary circuit and systemic circuit. So one of the most important points to remember right now is that for the blood to get to the systemic circuit, it always has to pass through the lungs first. As long as you're talking about someone, beyond development, right? So we're talking, I shouldn't say beyond development, but beyond birth. So once you're born, your lungs will open up and then you'll get blood supply. We'll talk about this later, but prior to birth, you do not have pulmonary blood supply. Um, you don't really have pulmonary function at all because you're not going to breathe in the womb, right? So, um, but this is assuming, right? This is in someone who's already been born. What is happening? The pulmonary circuit is critical in that case. So the flow of blood, and we'll go over this several times actually, and it's really important to know this. But the flow of blood is, we can start anywhere, but I like to start with the blood returning to the heart. It returns, through something called the vena cava, and then that'll be the right atrium. It'll go down to the right ventricle, then up through the pulmonary circuit, both lungs. It'll come back into the left atrium, and then go down into the left ventricle, and then to the aorta, and then to the rest of the body. So it's critical to understand that the lungs are first in the pathway. So if something is wrong with the lungs, that can affect blood flow after that, right? If there's pressure buildup in the lungs, if there's a blockage in the lungs, that will ultimately affect everything after that, which is the whole systemic circulation. So that's why you see people with heart failure that, they can have, um, pulmonary issues, right? Buildup of fluid in the lungs. And then you could have people with other types of heart failure that mostly have fluid buildup in the limbs and the rest of the body. But they're all connected, right? Every part of the circuit is connected. It's a continuous loop. So it's really one part of it will impact another part of it in most cases. Starting off with the basics of blood vessels, we do have an entire lecture, a very long lecture on blood vessels and how they're designed and how they dilate, how they constrict. But we're going to start off with the basics here in this introductory lecture. Three types of blood vessels or arteries. It's easy to be tempted basically into thinking that arteries always carry oxygen. That is false. Arteries always carry blood away from the heart, and then then they'll turn into capillaries, which we'll get into. Veins always carry blood back to the heart. Veins do not always carry deoxygenated blood. In both cases, there's an exception to whether or not the arteries or veins have oxygen or don't have oxygen. So that's not a good generalization to use. The best and the only accurate definition is the direction of blood flow. Is it away from the heart or towards the heart? Capillaries are in between arteries and veins. They are critical for exchanging nutrients into the tissues, removing waste from the tissues. So capillaries where all the exchanges take place, oxygen and nutrients into those tissues. So they're very thin, and some are very porous, some are less porous, and we'll talk about that later. So you'll see in the presentation, I have videos embedded. Sometimes they don't work very well on the recordings. So what I would like you to do is take the PowerPoints I'm going to provide to you and do that on your own. And let me know if you have any problems with the videos. None of the videos are essential because they're supplementary to what I'm talking about. So please don't be too concerned if you're not accessing the video. So first, for the heart, we start off with the right atrium that collects blood for the systemic circuit. That means from all the organs other than the lungs. The right ventricle pumps blood to the pulmonary circuit, and then so that's only going to the lungs. The left atrium collects blood from the pulmonary circuit. So the lungs, right? The lungs go, the right in between the right ventricle and the left atrium, right? That blood flow. And please become very familiar with the path of blood flow. The left ventricle pumps blood to the systemic circuit. That means the left ventricle generates the highest pressure in the entire body, right? Because it's pumping blood throughout the majority of your body. And I don't know how much you've had of this in physics or another course, but For any, if any flow rate, right, if you're pumping fluid at a specific rate, a volume per minute, right, milliliters per minute, the longer the pathway for that, if you're going to maintain that flow rate, the longer the pathway, the higher the pressure. So the longest pathway is in the systemic circuit. So you have the highest pressure generated in the systemic circuit. So your left ventricle is high pressure. So immediately after that, um, right into the aorta is very high pressure. Okay, the highest pressure in your body, and then it actually it's pretty simple. It declines from the aorta beyond. The blood pressure gets lower and lower and lower and lower, and after the capillaries, it's very low in the veins at that point. So in terms of the anatomy of the heart, again, just a little more on the anatomy. The great veins and arteries are at the base. I want to highlight the fact that the base in this case is the top. As we normally think of the base as the bottom of something. The base is the top because the apex, the apex comes to a point, and that's at the bottom of the heart. When you're looking someone in a normal position or standing position, the apex is at the bottom. That's the point. The base is at the top. The great veins and arteries are at the base. That would be things like the aorta, the pulmonary trunk, pulmonary veins, vena cava at the top there. And that's because they go, well, they either go into the atria or come out of the ventricles. The heart is surrounded by something called a pericardial sac. We'll get into that in a little bit more detail. That's not something I focus on a lot because it's not, it's important for the heart to, for the function of the heart, but it isn't the major functional unit of the heart, right? The pericardial sac just kind of lubricates the heart. It keeps fluid in there, and it protects the heart. The heart sits between two pleural cavities in the mediastinum. Okay, so between the lungs. So if we kind of look just at a kind of normal view, anterior view of the body, we see that the heart is embedded between the lungs. So interestingly, when the lungs contract and expand, that does have some ability to move the heart as well. So there's kind of some interdependency there, not a critical interdependency in terms of any mechanical force, but a little bit. So despite what's some cartoons or movies would lead you to believe, the heart is really close to the center. It's not really left-sided. Maybe the apex is, but it's pretty close to the center of the body. Okay, so not too much more to say about this. I just wanted to show you kind of where it's located. So if we look from a superior perspective, we did a cross section, you'd see again that the heart is embedded between the lungs there. And this kind of highlights the pericardial cavity right here, which is this fluid-filled space, which is, if you look at it, it's a continuous lining that goes around. It's like a double-walled, almost like a balloon, that is thought to protect the heart, cushion it, and reduce friction because of the fluid in there. There's not too much that I want you to memorize about this image. I just wanted you to get a perspective of physically where the heart is located and how it's in direct connection with the lungs there. So a little bit more on the pericardium. The pericardium is a double-lined fluid-filled sac, as I mentioned, and that surrounds the heart. Imagine in this case on the right that the fist would be the heart, and this balloon, and we'll just imagine the balloon might be not super inflated, but it's still got some air in it. If you push down on it, it's a single continuous wall or a single continuous layer, but well, that's probably not the correct way to say it. But basically, it is right a lining that goes around, and then it loops around and continues, but it's actually a double layer, right? So there are two layers to the pericardial sac. Okay, that we'll talk about now, but there's not too much to memorize here. So we have first we have the parietal pericardium, which is on the outside, and then the visceral pericardium is on the inside. Okay, again, parietal pericardium is on the outside, visceral pericardium is the layer on the inside. There's not too much that I want you to know about the pericardium other than the fact that patients can get infections there, pericarditis, right? So that in that case, they're going to need some kind of treatment. Other than that, just know that the pericardium is important, but not something pharmacists normally have to think about or deal with. So this is going to be the major anatomical features of the anterior surface of the heart. Okay, so I don't really want to go in any specific order here, so I think we can probably go with kind of almost like the flow, basically the flow of blood through the heart. So some of the structures here would be the right atrium. It's covered in something called an auricle, A-U-R-I-C-L-E, and that has this kind of weird, almost like shiny, wavy-like structure on it. Okay, so that would be the covering of the right atrium. Okay, remember the right atrium is filled with blood or receives blood from the vena cava. This is the superior vena cava, and the inferior one is hidden here. It would bring blood back from all the visceral organs like the abdomen, etc., and the lower limbs. Um, the left atrium is hidden here. You can see a little bit of it, but it may not be very well kind of depicted here, but the atria are a lot smaller than the ventricles. And you can see that they're smaller here, but in a real heart, they're actually even smaller. I would say a little smaller than it looks here. At least the preserved hearts that we get, the atria are very, very small. Okay, so then we have also the left ventricle. So it might not be that easy to see that there's a separation between the ventricles here, but if you look basically where the adipose is deposited, that's typically where you have these separations or the interventricular sulcus. Okay, and that also has coronary blood vessels that we'll talk about later. But you could almost see that there's a little bit of an indent there, and that would be the septum. So if you went inside of here and cut it open, you would see like a thick wall of muscle there that separates the two ventricles. Okay, so there's a left ventricle and the right ventricle. Of course, everything is opposite because we're looking at the front of the patient, but they're named assuming that, right, you are the person or the patient that contains the heart that we're talking about. So that means if you think about your own heart, right, the left ventricle is on the left side of your body, okay, when you're looking forward. So that's why they're named that way. It's pretty simple, but it's easy to mix it up sometimes. And then, as I mentioned, the right ventricle goes into the pulmonary trunk, okay, and that goes into the left lung and right lung. It's sometimes hard to figure this out or to see this, but if you have your own heart, if you were dissecting a heart, usually we would see, actually every time, the pulmonary trunk is always slightly anterior. It's hard to see here, but this pulmonary trunk is always a little more forward than the aorta, and that's a really good way to figure out what vessel is what vessel. Okay, in terms of the great vessels here. And then we have the aorta, which you can't see here, but it's going to come from the left ventricle, which crosses under the pulmonary trunk and comes out where you're going to have blood going to the rest of the body. That's feeding the majority of the body with blood. Okay, and we even have, for instance, the brachiocephalic trunk, which is going to go to the carotid artery, and then one of the arms, and then these two branch early on. They branch right off the aortic arch, whereas this one will branch later on. One of them again going to the brain, one of them going to the right arm, whereas these two branch immediately off the aortic arch. So this one will go to there's the other carotid artery, and this one goes to the left arm, which is the left subclavian artery. And that's about it for the major structures on the anterior superficial view of the heart. Okay, one more thing I guess I could add is the ligamentum arteriosum. that is connective tissue that is kind of vestigial because, and that means that it's, as you develop, right, once you're born, this becomes just basically scar tissue. But before that, there's actually, again, in the fetus, there's a connection between these two, between the pulmonary trunk and the aorta. And that's because, remember, your lungs aren't used when you're in the womb. So it's okay to mix blood from these, a vessel that would normally be deoxygenated with one that is normally oxygenated. Well, none of that matters when you're talking about a fetus because they're not, you're not getting pulmonary oxygen. You're getting oxygen from the mother. So it's very different in that case. So if you look at a posterior surface, we could more easily see some other structures. So now the left and right is more intuitive, right? So because we're looking from behind, the left atrium actually has four pulmonary veins going into it, two from the left lung, two from the right lung. And now you can see in the right atrium that we have an inferior vena cava and a superior vena cava. So it's pretty intuitive because the lower end, it receives all the blood from the abdominal organs and the lower limbs, like the legs, whereas the upper one receives blood from essentially like from the upper limbs and the brain. Okay, that's going to be the superior vena cava. So the whole point is here with the superior vena cava and the inferior vena cava is to get blood back to the heart because all this blood is already deoxygenated and it needs to be reoxygenated, so we're going to get it back to the heart. So the right atrium is the first point where the blood returns. That's the entryway. Okay, and I guess we could do that, go through that flow one more time here. So again, it goes into the right atrium, then the right ventricle, and then it goes in from the right ventricle, goes up the pulmonary trunk, which is really hard to see. Of course, you can't see where the blood flow is here or the continuation of the vessel, but goes to the pulmonary trunk, left pulmonary artery, right pulmonary artery, the lungs, and it goes back to the left atrium. And that's why these are called pulmonary veins, because the blood is coming from the lung, both lungs, and then from the left atrium to the left ventricle, then out the aorta through the rest of the body, right? So the reason why the left ventricle is next is because the blood has just immediately been oxygenated from the lungs. So now the left ventricle has this critical job of pumping that oxygenated blood through all the tissues, right? And we'll get into this later, but it also has to pump blood to itself, right? So the heart doesn't get its oxygen from the inside of the chambers, right? The heart gets its own oxygen from its own blood vessel supply, which is of course the coronary blood vessels. So we'll get into that later. But so where do the coronary blood vessels originate? So how does the heart feed itself with blood? Again, that's coming later. So in terms of the heart wall, the different layers here, we have the epicardium, which is the outer layer. That's also called the visceral pericardium, right? Because it's basically the inside of the pericardial sac that covers the heart. The myocardium is the middle layer. That's the muscular wall of the heart. We have concentric layers of cardiac muscle tissue. That means rings upon rings upon rings that get smaller and smaller inside of each other. And we'll see more on that later. The atrial myocardium wraps around the great vessels. And there are two divisions of the ventricular myocardium. Okay, so we have the left and right ventricle there. The endocardium is the inner layer, and that is simple squamous epithelium. You don't have to memorize the cell type there, again, but just understand that the endocardium is the very inside, which is actually in contact with the blood in the chambers, right? And the myocardium is the bulk of the muscle, and the epicardium is the outside. So like anything, epi is generally, on the outside, and endo is generally on the inside. So what does it actually look like for each layer? So again, we start off with the parietal pericardium. Then we have the fluid in the pericardial sac. Then we have the visceral pericardium, which is also the epicardium, same thing. Then we have all the muscle, which is the myocardium. And then we have the endocardium, okay, which has these cells in the endocardium, which again, these would be in direct contact with the blood in the chamber. And all chambers, both atria, both ventricles have this general design. Okay, but the muscle wall will be the muscle in the wall will be thicker or thinner depending on if it's an atrium or a ventricle. Of course, the ventricles have much thicker muscle. Particularly the left ventricle is the thickest muscle in the heart because it generates the highest pressure. So this is the whole idea of concentric layers of muscle. All it means is that you have muscle fibers getting smaller and smaller, or rings, basically rings within rings. So we have a larger ring, and then they're going to get smaller and smaller and smaller till they kind of wind around into like a circle. The same thing around each atrium. Not too much to memorize there. Cardiac muscle tissue on a more microscopic level has intercalated discs. The intercalated discs are structures that connect cardiac muscle cells. They're secured by structures called desmosomes. All the muscle cells are linked by gap junctions. Not only the muscle cells, but the nodal cells, which are the major conducting cells. They're also called pacemaker cells that we'll get into. The main point there, and don't worry too much about nodal cells right now, but the main point is that all cardiac cells are linked together by gap junctions, which if I'm not sure how much you remember from that, but all it is pores that allow the ions to flow, and we're typically talking about cations. So things like calcium and sodium flowing in through the gap junctions, and that allows one muscle cell to communicate with another one by spreading that chemical message, which is again the cations. The intercalated discs help to spread the force of contraction. So when one muscle contracts or one cell contracts, it will spread that force to adjacent cells through that connection. And of course, like I said, the gap junctions can help propagate, or they're critical for propagating the action potentials. So this is kind of what it looks like. So we have a single cardiac muscle cell that's got a lot of mitochondria. We have an intercalated disc that's a cross section here, and there's not too much more to say about it. One thing I do want to emphasize is that the muscle cells can branch, right? So one muscle cell can ultimately be connected to two or more, right? So they can branch and grow in terms of when they're stacked on top of each other. We could again branch out into a larger bunch of muscle, right? So we do have branching there. So that's really important for the function because we're starting with a very small signal coming from one of the nodal tissues, and that grows into a much bigger signal because it spreads through this branching. So again, the gap junctions are going to be between muscle cells. They allow ions to flow to say, well, if this muscle cell has an action potential and is activated, it could spread that action potential to the next one through these pores, right? Not too much more to say about that. I don't really ask a lot of questions on this material. I'm more interested in you knowing about the function of the heart, how it's regulated by things like epinephrine and norepinephrine, and how the pressure in the heart, how that controls the valves moving in and out, closing and opening, etc. So an actual image of cardiac muscle fibers is here. I was fortunate enough to be working in grad school. I worked next to a professor in a lab where he was growing cardiac muscle cells, and he showed me that a single cardiac muscle cell could contract on its own in this case, this image, you're seeing multiple cells fused together, which is normal. But even individual cells, they look just like this, but they could contract on their own. It was really cool to see that. Because they have that, it's called autorhythmic or pacemaker ability. And that's why, believe it or not, even though they're just video games, things like Mortal Kombat, when they take the heart out of a person in these games, the heart is still beating. That would actually still happen. That would really happen because the heart doesn't need the central nervous system to beat, right? It only needs the central nervous system to regulate faster or slower rhythms, not to have a rhythm in a period, right? So that's actually somewhat accurate. So what are the interesting characteristics of the cardiac muscle cells? Well, that would be they're quite small. They have a single central nucleus. There's branching interconnections between cells. As I mentioned, one cell can branch with multiple muscle fibers, and then they have intercalated discs. Um, Nothing on this slide is really test material, to be honest with you, because it's just the introduction. I like this table that I got from a text because it compares skeletal muscle with cardiac muscle. You definitely don't have to memorize everything here, but some of the stuff I think is important. Let me get into that. The main thing would be, let's see. I think, believe it or not, out of all this information on here, there's really not much I want to ask you about other than um, the types of contractions. Okay, the stimulus for contraction, and that would be the main thing, honestly. So what I want you to understand is that, this is really critical to understand actually, the cardiac muscle cells, um, they contract, but then they have a required or requisite relaxation period, then a long refractory period that prevents tetanic contractions. That means in cardiac muscle cells, um, right, they're going to have to relax no matter what, right? They relax at some point, unless you have some pathophysiology, right? A disease that's causing them to contract continuously, which is called a fibrillation, right? Like ventricular fibrillation or VFib. The cardiac muscle cells are supposed to relax, and that's hardwired or automatically programmed into them. Um, that's very different from skeletal muscle because if any of you have, well, really, you don't even have to have worked out or been in a gym lifting weights, but if that's an easy example. If you think about doing bench press, um, if your skeletal muscle could only sustain a contraction for as long as your cardiac muscle, you would never be able to do a bench press because as soon as you moved it a few inches, it would drop again, right? It would drop back onto your chest because you'd have that required relaxation period. So that's a huge difference, right? Your skeletal muscle has a tetanic contraction ability, and it's totally voluntary, whereas cardiac muscle is involuntary and it's got a required relaxation period. And the term refractory means, at least in the heart, it means that there's a period of time during which you can no longer activate a cardiac muscle cell, right? It's that required period where it's going to ignore any further action potentials and it will not contract, right? So that's normal and physiological. So other than that, the trigger for contraction would be calcium entry from the extracellular fluid and calcium release from the sarcoplasmic reticulum. Actually, for skeletal muscle, it's almost the same. So that's one where I do not want you to memorize any kind of difference. There's really no significant difference there, important difference. Okay, so the main thing is, yeah, I'd like you to look at the table and compare a lot of these things and just have one look at it. But in terms of commitment to memory, the most important thing is that how the contractions are different, right? Non-tetanic or relaxation period versus tetanic or sustained. So first, or now, we'll cover the internal anatomy and organization of the heart. So there's an interatrial septum, which separates the atria. There's an interventricular septum, which separates the ventricles. Also inside the heart are the AV valves, which I already alluded to the valves before. There is a video link there, but that takes you to an external website. So if if you'd like to do that on the PowerPoint that I'm uploading to D2L, feel free to do that. We will cover that multiple times, so it's not critical to view. So the AV valves, this is pretty simple. If you remember what the atria and the ventricles are, right? That's the upper chambers and the lower chambers. The atrioventricular valves, of course, are between the atria and the ventricles. So they connect them to each other. They're folds of fibrous tissue that extend into openings between the atria and ventricles. I encourage you to go and look at some images online. I also have an animation, or actually it's a video, not an animation, but a video of the dissections that we do in the lab sometimes, right, when we actually have the ability to do that. Basically, they're very, very thin. So the AV valves are almost transparent. It's almost, my best explanation would be like a nylon or very, very strong, almost like, even though they're not synthetic, they feel like almost like a strong synthetic material. Very thin, but extremely strong, like a well-made tent or something like that. So it's very interesting. You might like to think of valves as thick and rigid. These are not. They're thin and not that rigid. So the reason why the valves still work for their main purpose, right, which is to limit blood flow to only one direction, right, or to prevent backwards flow of blood, is because of the way they're designed, the way they're tethered to the muscle wall, and I'll show you that in a little bit. So again, they only permit blood flow in one direction. That's critical to understand, and that's only in the productive direction, which is from atria to ventricles. Okay, and this is only the AV valves, and we do have other valves, two more valves that we'll talk about. We'll talk about those other valves later on. So the right atrium has the superior vena cava, receives blood from head, neck, upper limbs, and chest. The inferior vena cava receives blood from the trunk, which is really below, it's below the chest, right? That's the trunk area. The viscera, which we're talking about, like the pancreas, the spleen, the stomach, other abdominal organs, and then the lower limbs. The right atrium has something called the coronary sinus. You'll see that in more detail in the lab portion, but that is where the cardiac veins return blood to the heart. So, the heart has its, like I said, it has its own blood supply that's supplying its muscle. So that blood supply has to eventually go back to the chambers of the heart and then back to the lungs to get more oxygen. So it does that through these cardiac veins, which then go to the coronary sinus again, and then right into the right atrium, where then the blood could eventually get back into the lungs again. Okay, so just please understand at this point, the main way for blood to go from the coronary blood vessels back to the right atrium is through the coronary sinus. The right atrium also contains the foramen ovale. Of course, a foramen is a hole or a cavity. Before birth, that's an opening through the interatrial septum. So again, before birth, it's normal to have a hole between both atria, and that's again because there's no reason to separate the blood supply to the lungs into the systemic circulation, because the lungs are not utilized before birth, right? So there's no separation of that blood supply. So the two atria are connected, but once a child is born, very quickly we should have scar tissue forming between the atria, and that's called the fossa ovalis, right? So the foramen ovale becomes the fossa ovalis, and that is to prevent oxygenated blood from mixing with deoxygenated blood. So that should happen, right? That should seal off very quickly after birth. And sometimes it does not, right? And then sometimes they need surgery, right? So it's, like anything, anything in this world, like things could go wrong, right? In any part of the body, things can go wrong, and including sealing off this foramen. So there's a lot of information on this slide. This is more of an anatomy slide. I definitely don't want to go over every structure, but I want to highlight the things that we've added that we've just talked about, which would be, again, the fossa ovalis, which in reality, when you get preserved hearts for dissection, it's very hard to find that actually, but that would be that scar tissue that would form, that was normally, right, that was originally the hole, the foramen between the atria. The other thing I wanted to highlight here is now you're starting to see the valves. This would be the right AV valve. This would be the left AV valve. Okay. Now this is going to be again in the anatomy portion of the course, but I want you to be familiar with this now, that the right AV valve is called tricuspid because there's 3 flaps. The left AV valve is called the bicuspid or mitral valve because it only has 2 flaps. In the history, that name there, mitral valve, is because in the Catholicism, the bishop has a mitre, which is the hat that they wear, and some folks believe that this 2-flap structure resembles a bishop's cap or hat. So that's just the history behind it. So there are 3 names, right? The left AV valve, or the mitral valve, or the bicuspid valve, because it has 2 flaps. So you never know who you're talking to, right? They might choose one term versus one term over another term. So it's good to be familiar with those terms. So this is what I mentioned. These are very thin, almost like nylon material. They're tethered to the muscle, actually tethered to the papillary muscle here with these strings called chordae tendineae. And this is really cool how this works. It might not even look like it could block blood flow, but what happens is when in this case, the right ventricle, when it contracts, it pulls these strings down, or the chordae tendineae. This becomes very tight. The valve cusps become very tight, but when the blood starts to go backwards, these slam together or slap together, right? All the flaps slap together. And the only thing preventing blood from going backwards is that these are stuck together, right? So the blood would go behind it, right behind it, and it would not be able to go back into the right atrium in that case. So these are not rigid valves, right? Their valves are really flexible, but very, very tough. And then on the left side, the same thing happens, except we only have 2 cusps. And that's, again, to prevent blood from flowing back from the left ventricle into the left atrium. Okay, so blood should never go backwards into the atria. And you'll see already here, they're showing you another valve, and that's hidden. The aortic one is hidden, but this is the pulmonary or pulmonic valve. They're also called semilunar valves because some folks apparently believe they look like a half moon. They kind of do in this case, but these semilunar, or in this case the pulmonary valve, what will happen is the blood will go through freely, right? And then if it tries to go backwards, it gets blocked because these close together like 3 cups or 3 bowls kind of pushing together. Okay, so the valves are actually organized or designed differently, right? The AV valves are designed very differently from the pulmonic valve or the aortic valve, which the aortic valve is hidden, but that's basically the same structure as this pulmonic valve for the most part. If we look at a real image, this is probably a sheep heart. At least it looks like the ones that we've dissected. I don't want to spend too much time on this, but hopefully you could easily see the structures here because they're labeled. And please compare this to the actual like cartoon diagram that we just used, and see if you could easily kind of identify these things. Maybe at some point crossing off or covering up the names. And you should be able to identify, at least on this one, be able to identify everything because it's not too much detail in the names here. Next, the right ventricle. Okay, so I know we just talked about all the chambers and all the valves because it was kind of convenient to do that, but we are going in order. We started with the right atrium, now we're on the right ventricle. Remember that attaches the free edges of the ventricle attached to the chordae tendineae from the papillary muscle of the ventricle, and that prevents the valve from opening backwards or inverting. The right AV valve, like I said, it's called the tricuspid. It opens from the right atrium to the right ventricle, has 3 cusps or flaps, and prevents backflow. The right ventricle has something called trabeculae carneae. I don't know that you'll hear that term a lot outside of this course because it's not something pharmacists need to really be very familiar with, but that is just the muscular ridges on the internal surface of the right and left ventricle. That is just basically the fact that it's almost like a spongy network, that muscle there, rather than a smooth muscle. Or rather than, I don't mean smooth muscle in the strict definition of it, but it's not shiny or smooth. It's more rough, right? And it's got a network or a sponginess, so that's called trabeculae carneae. The right ventricle has something called the moderator band. That is a ridge that contains part of the conducting system. For some reason, we evolved without a moderator band in the left ventricle. So it's kind of a thicker piece of tissue, basically, that travels across the right ventricle, and they believe that helps with coordinating the contractions of the cardiac muscle cells. I don't want you to know too much about the moderator band, honestly. So if we were looking at a real heart, you could see, and this is just kind of emphasizing the chordae tendineae. Remember, these are really strong fibers that connect. The chordae tendineae are not muscles, but they're very strong material that connects to the papillary muscles. And when your heart contracts, the papillary muscles will contract, pull these cords really tight, and that will prevent the valve flaps from inverting inside out. So that's all I really wanted to say about that. It's actually hard. It tells you here like what the perspective is from the inside of the right ventricle, but I would never expect you to know that from this image. So we're kind of going in order here. We went from the right atrium to the right ventricle. Remember, after that is the lungs or the pulmonary circuit. That contains the conus arteriosus, which is the beginning of the pulmonary trunk, right, or leads to the pulmonary trunk. So as soon as you leave the right ventricle, right, and it starts to develop that blood vessel shape, right? That's the conus arteriosus that leads to the pulmonary trunk. The pulmonary trunk divides into left and right pulmonary arteries. Blood flows through blood flows from the right ventricle to the pulmonary trunk through the pulmonary valve or pulmonic valve. Again, that's also called the pulmonic semilunar valve. And the pulmonary valve has 3 semilunar cusps or flaps. Then, because we've gone through the lungs, just imagine the blood has gone through the lungs. Now it's coming back to the heart, to the left atrium. There are 2 left and 2 right pulmonary veins that are bringing the blood back to the heart. And this is the example where these are veins that have oxygenated blood. This is that exception that I was talking about. Veins with oxygenated blood. So yes, they're returning to the heart, so they're veins, but they do have oxygen, more oxygen than most veins. And actually, let's make that more accurate. The pulmonary veins should have the most oxygen in the body because they're immediately coming from the lungs, right after the blood gets its oxygen supply. So that's important to understand, right? So you shouldn't have to memorize it. If you understand the flow of blood, right, you should understand that the purpose of the lungs, right, is to deposit oxygen into the blood. So the most oxygen should be as soon as the blood leaves leaves the lungs, and that's going to be the pulmonary veins. They deliver blood to the left atrium. Blood from the left atrium passes to the left ventricle through the left AV valve, or again, that's the mitral valve or the bicuspid valve. That's like all the valves, right? It's a one-way valve preventing backflow into the left atrium. Again, it's bicuspid because there are 2 flaps of tissue, right? Again, mitral as well. This might be surprising, but the left ventricle holds the same blood volume as the right ventricle. However, the muscle is much thicker there and more powerful. It's similar internally to the right ventricle, but does not have the moderator band. That's FYI for at least because this course has lecture exams and then lab exams. I don't want to spend any lecture exam questions on asking about the moderator band because that's more of an anatomical phenomenon or almost an anomaly because there's still debate as to whether or not it's important or what it actually does. But there is an anatomical difference there that you won't see the moderator band in the left ventricle. The left ventricle is the most critical. Really, out of all the chambers, the left ventricle, and they're all important, right? But the left ventricle is the pivotal one because that provides blood to the systemic circulation. So blood leaves the left ventricle through the aortic valve, or you could also call it the aortic semilunar valve. That goes into the ascending aorta because it's going up, right, relative to your body. It's ascending or going up. The ascending aorta turns into the aortic arch because it is a curve, and then becomes the descending aorta. And then I don't know how familiar you are with this, but your aorta goes really far down. The descending aorta goes down the midline of your body, all the way down your abdomen, very, very far down, and it branches into the kidneys, into your legs. So the descending aorta is a huge blood vessel down the center line of your body, right? So that'd be one of the worst places to get wounded, or if you got kind of who knows an accident that where you got a puncture there. That's obviously the midline of the body is one of the most dangerous places for that to happen. Not just in the chest, but all the way down because the abdomen has that abdominal aorta. So one more time, I'd like to highlight the structural differences between the left and right ventricles. The right ventricle wall is much thinner and develops less pressure than the left ventricle. And again, I want you to try not to memorize everything, but try to think about the reason for that. And that's because the right ventricle only pumps blood through the pulmonary circuit, which is much shorter, so much easier to get the blood through, whereas the left ventricle is pumping blood through a much larger circuit, right? So the left ventricle must be stronger. The right ventricle is pouch shaped and the left ventricle is more round, and you'll see that on the next slide. So it actually looks more like the left ventricle is almost like a circle within the whole heart, and the right ventricle would be like the outside of that circle. So it's kind of like a concentric, two concentric rings, one here, and then one which would be the left ventricle here. So it's very unique and interesting the way it's designed there. Okay, and that's really all I wanted to show, just to show you that the shape of the heart internally is a lot less obvious than people probably would expect. If you're looking at the phases of contraction, or really just diastole versus systole. Diastole is the same as relaxed or dilated, which is on the left. Systole is the same as contracting. So when it contracts, this kind of like the ventricle is kind of like a ring that gets shrunken or smaller, and whereas again, that's the left ventricle, and the right ventricle is more like a pouch. Okay, so if you look at that, you can kind of see that the volume is actually the same, but the shape is very different. So when the blood finally leaves the left ventricle, it goes into the aorta, and I wanted to spend a little bit of time talking about what happens when the blood immediately leaves, gets into the aorta. So remember, the aortic semilunar valve is going to have these three flaps, just like the pulmonary one. It'll have these three cusps or flaps, and if you cut the aorta kind of longitudinally and spread it open, you would see these kind of separation here, or the separation of the three flaps. What's unique about the aorta compared to the pulmonary trunk or the pulmonary valves, or I'm sorry, it's the pulmonary semilunar valve, but What's unique about the aortic semilunar valve is that it has under it, right under two of these flaps or cusps, we have the openings of the coronary arteries. So here's the opening for the right coronary artery. Here's the opening for the left coronary artery. So, and I know you're not seeing the whole heart here, so it might be a little harder to visualize. But if you go back to the image of the heart, think about where the aorta originates, right? And that's immediately after the left ventricle. And I want you to think about the fact that these coronary blood vessels start immediately when the blood leaves the heart, immediately in the aorta. So the second the blood passes this valve, right, it has a chance, some of it has a chance to go into this um, right or coronary artery, and then some into the left coronary artery, and then that blood supply goes right immediately to the cardiac muscle. So what that means is that the heart provides blood to itself before anything else, right? If it supplies itself with the highest, most oxygenated blood before it goes anywhere else. So please understand, where that happens and when that happens, and that's again in the right after the aortic semilunar valve. Remember that blood is highly oxygenated because it came from the pulmonary veins to the left atrium, then the left ventricle, and now the aorta. So this is anatomy, but it's also really important to understand. So how does the heart get very oxygenated blood, and where does that circuit begin? And this is right here where it begins. One more thing I wanted to add was that, see, if you look at these flaps, you can kind of imagine how blood is going up, right, out of the ventricle through the aorta. These flaps will actually be pushed against the wall of the aorta, and they'll actually cover these coronary vessels, right? You'll actually cover the coronary vessels. So that doesn't seem healthy, right, or good. Why would you block the coronary blood supply? Well, the reality is that during contraction or systole, when these valve cusps are pushed against the wall, you actually don't get coronary blood supply, right? The coronary blood supply actually occurs, believe it or not, when the heart is relaxing. So when the heart starts to relax, the blood is no longer moving up. It tries to move backwards, but these open up like bowls or cups. They open up, they fill with blood, and that alleviates this blockage, or it opens up the coronary arteries in that point, so they're no longer blocked. So the coronary arteries get most of their blood supply during diastole, or when the heart is relaxing. And when I say the heart is relaxing, I mean the ventricles, because those do most of the workload of the heart. So I have a few slides here, and I don't know that I clarified this before, but I do have images from multiple books. And I don't remember if this is in yours, but over the years I've used multiple textbooks, and I've retained the images that I thought were useful. And I like these ones that show the valves at different stages. So this one is showing a cross section here. If you look at the whole heart image, you get a cross section, and what you're seeing is that, so what valves are open and what valves are closed during different stages. So the most important thing to start off with is, what stage are we in? We are in the relaxed ventricle stage. That's called diastole, by the way. And again, we'll go over that in more detail later. We'll go over the cardiac cycle. But relaxed ventricles, I want you to think about that. If the ventricles are relaxed, right, that means the blood at that point in the ventricles should have low pressure, right? So what's happening is when the ventricles are relaxed, the pressure is low enough so that the AV valves can open so blood can flow from the atria into the ventricles. So why do you think, though, the aortic valve will be closed and the pulmonary valve will be closed? And there's a real good answer for that, and that's because, right, when the ventricles are relaxed, that happened right after they pumped a bunch of blood into the pulmonary trunk and the aorta, right? Right after that, then the ventricles will relax. So remember, so if there's a bunch of blood here and here above this, right, in the, again, the pulmonary trunk and the aorta, that blood's going to try to go backwards, right, because the ventricles are relaxing, all the pressure has been built up in these blood vessels. It's going to try to go backwards, and when it does, these valves are designed to stop that, right? They slam together, and right, so you should understand that the aortic valve and the pulmonary valve, those will be closed at the same time, and that is during diastole, whereas during diastole, the AV valves will be open to fill up. And that's a simplified version of the cardiac cycle because there are going to be brief moments where all the valves are closed, and that's called the isovolumetric phase, and we're going to cover that later on. So if we look at a frontal section, what'll happen is, again, during diastole or relaxation, this is low pressure, this is slightly higher pressure in the left atrium, so blood will come right from the pulmonary veins, passively go into the left ventricle. That valve's not going to cause any problems because it's only designed to close in the opposite direction, right? This valve, which is the aortic valve, is closed because the pressure, again, is low in the ventricle, high in the aorta. So if the blood tries to go backwards, this valve is designed to close, right? So it's all based on the structure of the valve and what it's intended to do, right? So if the valve is intended to close when the pressure is higher in the aorta, then hopefully it'll do that. If it's designed to close when the pressure is higher in the ventricle, well, that should be in the next phase. That should be in the contractile phase, or systole. So this is just led us right to, again, this slide, which is systole or contracting ventricles. When the ventricles are contracting, the pressure in the ventricles are going to be higher than the pressure in the atria. We don't want blood to move backwards, so the valves are designed to close, right? And we know, so these are the AV valves because we have a bicuspid and then a tricuspid, so they're different. So we know those are the AV valves, and plus they're in the center, kind of like more in the middle, whereas the semilunar valves are more towards the anterior. The semilunar valve should be open because the blood in the ventricles will have higher pressure because the ventricles are contracting, whereas the aorta in the pulmonary trunk, they've had time to move their blood forward. It's trickled forward or spread forward into the other blood vessels. So the aortic pressure and the pulmonary pressure is going to be, pulmonary trunk pressure is going to be low, right? Low compared to the ventricles, I should say, right? And the only thing that matters is the pressure difference. So not the the absolute. So what is, how many millimeters of mercury is it? Is 130 millimeters of mercury? Is it 120? That's not as important as the pressure difference, right? So as long as the pressure in the ventricles is higher than the pressure in these great vessels, the blood should move forward into these great vessels, again, aorta and pulmonary trunk. If we do, again, the frontal view, you'll see that during contraction, which is called systole, these balloon up like a parachute. They slam together. Blood is blocked from moving backwards. It can only move forwards, again, because this valve, the aortic valve, is designed to open when blood is moving from the ventricle to the aorta, and that's the same as the pulmonary trunk, the pulmonic valve, same thing. The next few slides are going to be on the connective tissues in the cardiac skeleton. So basically, these are the structures of the heart that are not really considered cardiac muscle, but they're going to be important for cardiac function. So the connective tissue fibers would be something like collagen or fibroblasts. We're talking about, again, not the muscle tissue. So it's the surrounding tissues. It actually it's embedded in with, around the cardiac muscle tissue. So the connective tissue fibers physically support cardiac muscle fibers to give them kind of like a fortification or strength, distribute the force of contraction. So again, as one muscle fiber or one group of muscle fibers contracts, the connected tissue the connective tissue that's connecting that all together will distribute that contraction to the other portions of the muscle. Connective tissue fibers add strength and prevent overexpansion of the heart. So when the heart might get a lot of blood supply during exercise, the connective tissue is really important to prevent the heart from expanding too much. The connective tissue actually provides elasticity that helps return the heart to its original size and shape after contraction as well. So when the heart, releases its blood during contraction, and then it basically is going to automatically kind of shrink back down. The chambers are going to, automatically relax, and that's based on a lot of that's based on the connective tissue elasticity. The cardiac skeleton is a strange term because it has nothing to do with bones. It is the four bands around the heart valves. So every heart valve has a ring around it of connective tissue, and that stabilizes the valves. And just as important, if not more importantly, the cardiac skeleton electrically insulates the ventricular cells from the atrial cells. That means around every valve that tissue is not conductive. So the only piece of tissue that's conducting a signal from the atria to the ventricles is called the AV node, which is kind of in the center of the heart. So we don't want conduction to happen randomly around, from atria to ventricles. We want that conduction to be channeled down a certain path, and we'll be talking about that fairly soon. As I mentioned earlier, the heart gets its own blood supply from itself through the coronary circulation, which, again, as a reminder, that starts in the aorta. It goes throughout the entire, the epicardium, mid-myocardium, endocardium, and the entire heart's going to get its own blood supply from the coronary arteries. Then they turn into capillaries and then coronary veins, which drain into the coronary sinus and then the right atrium. I don't have a lot of questions on coronary artery anatomy. Okay, so I don't think it's critical to understand where all the coronary arteries are and all their names. More important to understand their function. Of course, their main function is to deliver oxygen to the muscle tissue. So we have left and right coronary arteries, which originate at the aortic sinuses. Okay, remember the coronary arteries originate, like I said, right under the aortic semilunar valve flaps. That's also considered the aortic sinuses in there. High blood pressure, elastic rebound, is going to force blood through coronary arteries between contractions. I want to reiterate that. Again, the coronary arteries get most of their blood between contractions. That means not during the contractile phase, but during the relaxation phase. It's when the coronary arteries get most of their blood supply. That's because that's the only time that the entryways are available because the valve cusps are open. The right coronary artery supplies blood to the right atrium, portions of both ventricles, and cells of the sinoatrial and atrioventricular nodes. Those are specialized cells that initiate the signal for the heart to contract, which we'll talk about very soon. The marginal arteries are on the surface of the right ventricle, and then we also have a posterior interventricular artery, which is between the ventricles. None of this is going to be pertinent for the lecture exam for cardio. Left coronary artery supplies blood to the left ventricle, left atrium, and interventricular septum. In terms of the cardiac veins, right, so we talked about the coronary arteries. The cardiac veins are your coronary veins, basically. It's the small veins on the heart and within the muscle of the heart. The great cardiac vein drains blood from the area of the anterior interventricular artery into the coronary sinus. The anterior cardiac veins empty into the right atrium. The posterior cardiac vein, middle cardiac vein, and small cardiac vein empty into the great cardiac vein or coronary sinus. The more important thing is to understand that your heart, just like the rest of the body, the heart has its own arteries, capillaries, and veins, which are subject to the same processes, right? Same processes for the rest of the body. So the capillaries are critical for oxygen exchange and nutrient exchange and waste removal. It's important to understand that the cardiac veins ultimately drain into the right atrium. So then the blood that's deoxygenated from all that muscle use, right, all that deoxygenated blood is going to quickly get back into the lungs to be reoxygenated again. So the coronary circuit is very short, right? It's right atrium, right ventricle, lungs, um, left atrium, left ventricle, coronary arteries, coronary, capillaries and coronary veins, and then back to the right atrium. So it's a very short circuit. Again, this is just to make it easier to understand, but you really are not responsible for this, especially for the lecture exam. The coronary blood supply, the naming of the structure is going to be more relevant to the lab exam, and I'll further clarify which ones are critical before that exam. So just understand that, again, the coronary blood supply typically travels down between ventricles and between atria and ventricles in these sulci or sulcuses. And every one of these is going to have, we're going to have a coronary artery which branches, and then that returns blood through the coronary vein. And understand that it all has to wrap around and eventually reach the right atrium. So you'll see it'll all eventually come back and get bigger and bigger into the coronary sinus, which is the biggest coronary vein. It dumps right into the right atrium, so it could return to the lungs very quickly. And that's the main point to understand here. So we talked about the basic anatomy of the heart, and now we're getting into something just a little bit more complicated, and that's the conducting system of the heart. We're going to start off with the basic structures of the conduction system, and then pretty soon we'll get into the actual electrophysiology, and that will be the action potentials in the nodal cell types. So we're going to start at the top left here, which would be actually in the right atrium. Okay, so that's where we're going to have the sinoatrial node. Okay, so you're going to kind of have to imagine the shape of the heart, and you can see the shape here if you just look at the conductive tissue. So just imagine the rest of the heart is here, and embedded in the heart is what's called this nodal tissue. The nodal tissue is special tissue because all of it is autorhythmic, or called pacemaker tissue, and that's because it forms its own, really its own rhythm without required input from the brain or the central nervous system. And it doesn't mean the central nervous system can't affect it. It means that without the central nervous system, this nodal tissue will give a constant rhythm, right? It won't go faster, it won't go slower, and that's specifically to control the heart, right, the heart rate. So it starts off, the signal starts off in the sinoatrial node or SA node. Okay, the SA node dominates the heart rate because the action potentials there are automatically generated more frequently than in any other location in the heart, right? So that's your, 70 to 100 beats per minute. Okay, and that's going to depend on whether or not you have sympathetic nervous system input or parasympathetic nervous system input. But generally 70 to 100 beats per minute at rest. And what it does is then it travels to throughout the whole atria, both atria, right? And then all of that comes together and converges at this point called the AV node. That's the atrioventricular node. So in a healthy heart, the only way the signal gets from the atria into the ventricles is through this one location called the AV node. Okay, so just imagine though all this conductive tissue is going to be able to spread its signal through the gap junctions all throughout the muscle tissue as well, right? So both atria are going to contract approximately at the same time. Okay, to the naked eye, it probably would look like it's exactly the same. And then going down, you're talking about, again, going through the AV node, where some people consider that kind of a bottleneck, or a toll booth or something like that, because things slow down, the traffic slows down there. So the conduction slows down long enough so that the atria will finish their contraction before the ventricles contract. And that makes sense because the blood flows first from the atria and then into the ventricles. So then the signal will travel down into something called his bundle, which has the left branch and the right branch. Okay, what's really, to me, one of the most interesting phenomena, if you look at EKG abnormalities, is if someone has a bundle branch block, like if they just have a single side of this not functioning, what you'll see is that they'll have two different, like they'll have actually like a duplication of a portion of their EKG, which would be the QRS complex, and we'll get into that later on. But you'll see a really cool good duplication of that part of the EKG. So blocks can occur, single-sided blocks, double-sided blocks. So a lot of pathophysiology can occur throughout the nodal tissue, but we're not getting into that too much now. That travels down, okay, and then it's going to branch to multiple locations. Finally, it reaches something called the Purkinje fibers, and that's the very end of the nodal tissue. And those Purkinje fibers will innervate the ventricular muscle, and approximately again at the same time on both sides, left ventricle, right ventricle, and that will immediately then cause ventricular contraction. It's important to note that the AV node, really in all this nodal tissue, is autorhythmic. So if your SA node were not functioning correctly, if it were damaged, if it weren't generating a signal, or the signal weren't getting conducted into the rest of the nodal tissue, then your AV node would dominate your heart rate, and that would be slower because the AV node beats the autorhythmicity slower than the SA node. And if the AV node weren't working correctly, or if it were blocked because of tissue damage, then something down here, maybe in the bundle branch, one of the bundle branches, or even lower, would dominate your heart rate, which would then even be slower than that. So you have these kind of backup mechanisms that if one portion of the nodal tissue doesn't control the heart rate, then another portion will do that. And again, the only reason why the SA node wouldn't be dominating the rate is if, even if it's firing its action potential, there might be poor conduction, after that, and then it would isolate it electrically from the rest of the heart. So some other part of the heart would have to dominate. Again, that would typically be the AV node. And again, please feel free to look at the video. It's not required. It might help you a little bit to understand this concept of the nodal tissue. So a little more on the conducting system. Again, the heart is unique in that it contains these special cells that are autorhythmic. That means they spontaneously depolarize and create action potentials. That's what I was just talking about with the nodal tissue. These cells are called, also called pacemaker cells. Again, and I mentioned that they're called nodal cells. So please, at this point, understand if I say pacemaker or nodal, it means the same thing. And like I said, it's because of the nodal tissue that the atria contract before the ventricles, and the heart can contract without a signal from the brain. Okay, so the only thing the heart needs to beat is the appropriate energy source, like glucose or fatty acids, or well, it needs that, and it needs electrolytes, of course, right? All the action potentials depend on electrolyte gradients. Okay, so this kind of summarizes the two main cell types in the heart. The first one is the nodal cells, which is a small mass, which is the conducting system, and the muscle cells is the majority of the heart. That would be called cardiomyocytes for contraction. So again, to review, the main structures of the conducting system are the SA node, that's in the right atrium. The AV node is between the atria and the ventricles. Bundle of His and the branches are below that. And then the remainder of the myocardium has the ability to conduct action potentials, but is not as autorhythmic as the SA and the AV nodes. That means no portion of your heart should initiate a signal or action potential at a frequency faster than the SA or the AV node. So that means the rule of thumb is that in the heart, whatever piece of tissue generates a signal fastest will dominate your rate. Okay, so whoever decides to go first controls everybody else. So that's supposed to be the SA node. Otherwise, it's going to be the AV node, hopefully, right? There are examples where there are electrolyte abnormalities, where a portion of the heart would dominate, would take over the rate, and that could be muscle tissue, which is very pathological, right? And that's when you get things like ventricular fibrillation and things like that. So this is the kind of intro to the cardiac cycle, even though we kind of talked about it, to some extent already. The cardiac cycle begins with an action potential in the SA node, which happens automatically, right? It's going to happen automatically. There's no thought involved. There's um, no required central nervous system involvement. That travels through the atrial muscle to cause atrial contraction. That merges at the AV node, slows down, and then it continues to his Purkinje system. Finally, spreads through the ventricles and terminates. And the key here is that a really important point is that any piece of cardiac tissue that was recently activated should be refractory to further activation. That means that it should ignore any further stimuli for a fraction of a second, right? And that's to prevent the heart from beating constantly. More accurately than that, is to prevent individual muscle fibers from being reactivated prematurely, right? So then it won't, in that case, it wouldn't function as a single unit. The muscle fibers would be functioning individually, which is not a good thing. So there's something in the electrophysiology called the prepotential, that's also called the pacemaker potential. Um, that is basically it's a resting potential of the conducting cells, which gradually depolarizes towards threshold. So the SA node depolarizes first and then establishes, as I said, the heart rate.
Action potentials originate in the sinoatrial node and travel across the wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
So this is just a review of the components of the conducting system. I'm not going to say too much because we already went over all of this. So please be familiar with this anatomy. Okay, so this is the actual action potential tracing that you're going to see. This is the electrophysiology. So the first thing I notice, as long as, first of all, I know we're looking at cardiac tissue because that's the topic, but, is this looking at nodal tissue or cardiac muscle tissue is the first question I always ask myself. And I know immediately that it's nodal tissue because it's a little hill rather than it's not a very sharp slope with a spike at the top. And it may not be clear what I mean now, but you're going to see later on when you get into the muscle tissue, it's a much sharper slope, with a very sharp spike and then a plateau. When you see a little mound like this, it's automatically, you should think it's nodal tissue. So what happens in nodal tissue is that it's this really, really miraculous thing that it automatically, the potential, and that means the inside of the cell is becoming more positive, right, relative to the outside, and still, right, it's still, when it gets to threshold, it's still somewhat negative in there, but it's still getting slowly more and more positive, closer to positive, right? So it's going up. That happens automatically because of a various array of channels, sodium channels, mostly, and calcium channels that are called leaky. They're leaky channels because the electrolytes leak in constantly, right? Those channels don't have to be open by a specific event. They're always leaking. So the cations gradually come in. You reach a certain threshold voltage, which is about -40 millivolts. That then does open other channels, which are primarily the voltage-dependent calcium channels, which are also called L-type calcium channels. Calcium rushes in, right? And this is a tracing from an individual cell, but I want you to always, in every single case, because the heart is connected, right? Every cell is connected to other cells. Always think, well, what is happening then to the surrounding cells in this situation? And that is that when the cations go into this cell, right, there's going to be a surplus of calcium there. Remember, there's nothing stopping that calcium from moving to another cell through the gap junctions and then activating the surrounding cells, right, or that surrounding cell. So, yeah, the rule of thumb here is that if one cell is activated, the surrounding cells should then be activated, and then that should travel throughout the whole heart. Okay, so all it takes is one single cell to trigger its action potential, and that will set the whole heart, right, really trigger the whole heart to contract. Okay, so please understand that that pacemaker or potential or pre-potential is automatic. Please understand that the upward slope is from calcium influx. And I didn't mention this yet, but I'm going to do it now. The downward slope is from potassium efflux or potassium loss. And then the calcium channels will close also in that downward slope. And these do have names. These phases have names 403, but we'll go over that in a little bit. So now we have the nodal cell action potential again, but all the cations are listed. Okay, and I want you to make note of the top here is what we just looked at. That's the membrane potential. On the bottom, though, that is permeability or relative permeability to the different ions. So I want you to first understand that they're not. The bottom there is not telling you what direction the cations are flowing inside or outside the cell. It's just telling you how fast the ions are flowing or what is the permeability. So if you look at the beginning, again, these are on the same timeline. So in the beginning, sodium and calcium is entering. So notice the sodium permeability is going up. The calcium permeability eventually goes up. Okay, and that's constant, right? Those are the leaky channels causing this kind of pre-potential. And then as you get to threshold, notice there's a different calcium channel called the L-type calcium channel that opens up, and then you get a rush of calcium. And they, again, that corresponds to this upward slope in the membrane potential as calcium goes in. Okay, and then when the potential drops back down, you get a closure of the calcium channels and then an opening of the potassium channels. Remember, potassium wants to get out of the cells because really it's all starting with the sodium potassium ATPase pump, which is energy driven, and that is forcing a lot of potassium in normally, right? So then when you open up potassium channels, the potassium wants to get out because there's a very high concentration intracellularly, and vice versa. Remember, the sodium wants to come in because the sodium potassium ATPase pump is always pumping it out. So the energy for all this electrolyte flow is based primarily on the sodium potassium ATPase pump. And calcium is always really concentrated outside the cell in a resting cell. So it also wants to rush in as soon as the channel's open. So the main ion that's flowing out would be potassium. The ions flowing in are sodium and calcium. So it's important to understand when that happens. The fact that there's at least two different calcium channels, okay, and one major sodium channel, at least for we're talking about nodal tissue here, again. So it's going to be a little different when we're talking about muscle tissue. So this is an interactive video that is going to show the action potentials in the SA node. Again, normally you should be able to use this on your own and control it, but you would have to download the ability or add the ability to use Flash and PowerPoint. So what I want to do is go through it for you in case you don't have access, again, and you don't have Flash activated on PowerPoint. So the only thing we're adding here is basically, so what are the ion channels doing at different points in the SA nodal action potential? So because these are nodal cells, the really calcium is going to be critical for the conduction in this case, and for the rise in the voltage. But anyway, let's start from the beginning. So we have a pacemaker potential. So what they're showing you here is that in the very early phase, sodium is going in. That's called the sodium funny channel, which you don't need to know. We finally have medications that affect some of these early channels in the pacemaker potential, whereas for many decades we did not. So just in the past several years, these medications started. Well, a particular medication was developed to affect these early channels. Sodium rushes in, or actually slowly leaks in the beginning. Okay, and down here they're showing you the permeability to each ion, and it's color coded. The permeability to sodium is going up, and that's kind of like I guess it's purple. The other one almost looks purple too, but we'll say the normal purple color sodium is sodium going in. Okay, and then another phase is where and it already closed, but they showed you this is the T-type calcium or transient calcium channel. I'll go back just to show you that again. Again, the second part of the pacemaker potential is now calcium coming in, and that's not the L-type, but that's the T-type calcium channel, and there it is. So these two leaky channels are responsible for this automatic or autorhythmic potential in your nodal cells that will allow your cells to fire without central nervous system input. And then when we reach threshold voltage, remember this is not that, it might sound complicated, but the way these channels work is not that complicated because you reach a specific voltage and they naturally will open. There's got to be a conformational change of some sort. The channels will open. In this case, you should understand that when you reach a high enough voltage, you open voltage dependent channels, right? And that's voltage dependent calcium channels called the L-type calcium channels, which happen to be, and this is FYI, those happen to be the main target of drugs like verapamil and diltiazem that slow down the heart rate. So L-type opens, calcium rushes in much faster now, okay? And when you get to the top of this, right, get to this peak, the calcium channels will start to close, and then the potassium channels will start to open, and obviously potassium has to go outward because it is concentrated inside the cell, right? So you can see down here what permeabilities are changing. At the peak slope here, the highest or steepest slope, we had a really large calcium permeability. So now you should understand calcium is the most important ion for this sharp upward slope, which is really, we could say calcium is one of the most important ions for conduction. Only in the nodal tissue is it critical for that conduction. Okay, so it comes back down because of potassium leaving, that's making the inside of the cell more negative. And then it repeats, right, the pacemaker potential. So it's going to be a cycle, right, over and over. So an individual cell will do this on its own, right? I have a video showing you how an individual cell can do that. So the only thing at all that's making the heart work as a single unit is that the first cell to fire an action potential is going to trigger all the cells in the heart, right? It's going to spread that action potential. So as long as those cells receive a signal from somewhere else before they generate their own signal, they're just going to be like kind of pawns or um, basically subservient to the demands of the nodal cells, right? Particularly the SA nodal cell. All the other cells will follow that as long as the SA node is fast enough. So it's whoever's fastest dominates the rhythm. So now that we talked about the conducting system and the action potentials, I think we can start looking at the EKG and then talking about what does the EKG mean and how is that related to the heart activity. And it's actually, we can get very complicated, but we don't necessarily need to. So when you look at an EKG, anytime you have a wave, a spike or a wave, that means you have a large amount of either depolarization or repolarization, right? That means generally a large amount of muscle mass. It's got to be the muscle because the nodal tissue is literally physically not enough mass to create a large enough current to really affect the EKG. So the EKG, anything obvious on the EKG that's deviating from the baseline is going to be muscle tissue. So notice when the SA node is firing, we're pretty much flat on the EKG at the beginning there. When the signal spreads throughout the entire atrial muscle, which is in yellow there, we will see the P wave, which is the first wave on the EKG, which is down here. Okay, when the signal then travels into the AV node, where the atria would be relaxing, the ventricles have not contracted yet, so we're in that bottleneck or toll booth, so we're stuck in the AV node. That will be the flat point in between the P and the QRS. Right, P is always first, and then the QRS would be coming next. But in between that, so where there's that flat point, that's where the action potential is in the AV node. When the ventricles are finally contracting, that is shown as right, this entire QRS. Again, the bottom spike is Q, the very top is R, and then the bottom one again is S. That entire QRS complex is just ventricular depolarization, only the depolarization part. And then when the ventricles finally relax, we have the T wave, right? So that means either muscle contraction or relaxation will create a wave or some obvious signal on the EKG, right? So a complex or wave. Whereas anytime we have a flat point on the EKG, there's the muscle tissue is not really depolarizing or repolarizing. So I already talked about the first flat point, which is the AV node. The second flat point, you may be able to guess, is a little bit more complicated, but this is when the ventricles have contracted, but now they're stuck temporarily in a contracted state, right? And this is where it gets a little bit more complicated, that even though the ventricles are fully depolarized and contracted, you still have a flat point here because the ventricles have reached their maximum depolarization. So the electrical activity has stopped or been made flat or plateaued. So you also see a plateau or a flat point on the EKG. And then when the ventricles finally start to show more current or electrical activity when they repolarize, you get the T wave. So the waves are based on electrical activity. And regardless of what the voltage is, if it's stable or steady, then you won't see any wave on the EKG. When the voltage changes because the muscle is depolarizing or repolarizing, you'll see a deviation on the EKG. So this slide is actually a review of the heart rate and how it's, as I mentioned before, how it's dominated by different nodes um, depending on whether or not they're functioning correctly. So the SA node is, again, just to reiterate, that's going to generate the highest frequency. That means 80 to 100 action potentials per minute or beats per minute. However, parasympathetic stimulation slows down the heart rate. That means if you're resting, just sitting, your heart rate should not really be 100, right? Unless you're really hypercaffeinated or nervous, right? Your heart rate should be, between 70 and 100, but really closer to 70. Okay, so unless you're an athlete, which then it would be much, much lower. But again, if your heart were taken out of your body, were isolated, it would be faster because you no longer have the parasympathetic nervous system input, because at rest, the parasympathetic nervous system dominates and has the most innervation of the heart. So that would slow down your baseline heart rate to about 70 instead of 100. The AV node generates 40 to 60 action potentials per minute. And the way that works is that as long as the SA node is working correctly, the AV node won't really get to fire on its own because it'll receive a signal from the atria before it fires its own signal. So that's because the SA node activates the atria activate the AV node. So the AV node won't really get to shine or dominate unless the SA node or atria are not conducting the signal. Then the SA node, I'm sorry, as I mentioned, the SA node dominates. If it's not functioning, the AV node will dominate. If the AV node is not functioning, the His-Purkinje system will determine the heart rate. And in that case, you're going to have a very, very slow heart rate if your AV node is not working. And when I say heart rate, that typically means the ventricular rate, because the ventricles are what are really generating your pulse. The atria are not pushing blood into the systemic circulation. So again, ventricles generate pulse. Ventricles are really what we're talking about when we're talking about heart rate. If your AV node is not functioning, the ventricles will generally generate a very slow rhythm um, due to the His-Purkinje system, which might be less than 40 or less beats per minute, which is not generally bearable, right? It's really unhealthy and unsafe, of course, to get a heart rate that low, unless you're an athlete and your heart is so efficient that it's pumping so much volume per beat that it can beat much, much slower. Again, that's pretty rare. So some of you might have seen a heart rate in the 40s or less, but um, you're probably then running a lot or something like that. So it's pretty cool if you can get to that point. It's pretty interesting, but it's challenging. So this is actually some pathophysiological terms. So abnormal pacemaker function. So what happens if your heart rate is really slow? That's called bradycardia. Um, Abnormally fast is tachycardia. You may remember that in your car, a tachometer is measuring the rotations per minute, or RPMs. Okay, so that's the rate, right? Tachycardia is abnormally fast heart rate. Bradycardia is normally slow. Ectopic pacemaker is what I kind of alluded to already, that a portion of the heart can dominate the rhythm when it's really not supposed to. So that's abnormal cells that generate a high rate of action potentials. They work without the conducting system, or they don't need the normal conduction system, and they disrupt ventricular contractions. That means, in many cases, it could be in the ventricles where you have a piece of muscle tissue that is firing on its own, and it's not supposed to be. Right? It's supposed to wait for the signal from the AV node. So if that happens, you can easily have really get like ventricular fibrillation, or definitely some kind of real issue with moving the blood forward and having low cardiac output. So kind of just for fun, I wanted to show you what an individual cardiomyocyte would look like. Actually, so this is a real one in a culture dish or petri dish. And as long as you provide it, an energy source such as glucose, oxygen, and electrolytes, it will beat on its own. So this is still true for the entire heart. So if any part of the heart doesn't receive a signal frequently enough, it will start to generate its own rhythm, which could be a problem, right? That can put one part of the heart out of sync with the rest of the heart in terms of when it is contracting. So in this video, it starts off a little slow, and then unfortunately, I don't think they tell you when this happens, but at some point they add, I think it's epinephrine. And there it is, I think, where it started beating faster. So I've already introduced you to the EKG, but now we're going to talk about it kind of more formally, the different components of it. So first of all, you can also call it ECG. That would be primarily in the United States. But I think even in the US, they've adopted EKG, of course, more commonly. But either one of those is acceptable. It's a recording of the electrical events in the heart. That's what the EKG is. So it's important to remember the EKG is strictly recording the current of ion flow, right? The ion flow in the heart. So yes, it usually should correspond with contraction and relaxation, but please remember contraction of the heart is based on calcium influx. When the heart depolarizes, that's actually the sodium going in in the muscle tissue, which we'll cover in a little bit. So I want you to understand that the most direct correlation or the direct cause of the EKG waves is the electrical activity and not really the muscle contraction. The EKG is obtained by electrodes at specific body locations. Experts can look for abnormal patterns to diagnose damage. There are a lot of computer programs, I believe, that can help to identify, very quickly identify problems with the EKG, so that doesn't have to be done manually every time. Now, we're not going to get into this in this course, but cardiologists can look up at up to 12 leads, and what that means by leads is that the way they place the electrodes on the body will allow them to look at the current flowing in the heart at different angles. So from front to back of the heart, from top to bottom of the heart, how is the current flowing? That is much more advanced than we're going to need to get, or that I'm really able to get in this course. So pharmacists are generally going to be looking at your standard like first lead, which is going to be simple. We're going to see your standard P, QRS, and T complex. Some of the other leads won't show that, um, but the reason why we only really need the first lead is because that's going to show us things like the QT interval duration, which is the most commonly affected region of the EKG by drugs. So again, we talked about these, but now I actually have them on the slide. So the features of the EKG are the P wave, and you're going to be responsible for knowing what part of the heart is depolarizing or repolarizing um, during these waves, and then during the flat phases, where is the action potential? Where is it traveling? So the P wave is atrial depolarization. Okay, so anytime muscle tissue depolarizes or repolarizes, you'll see a wave. After the P wave, it's flat. That flat region is where the signal is stuck in the AV node. Anytime the signal is in the AV or nodal tissue, you will not see any wave because the nodal tissue is very small. So even if it's depolarizing, it doesn't produce a large enough current to show up on the surface of the skin where the electrodes are. QRS complex is strictly, well, that's ventricular depolarization. And all that means is they're going from more negative to less negative. So they're getting more positive, those cells on the inside. Now, you may already know this, but I'll say it just in case. But the atrial repolarization, which means atrial recovery or atrial relaxation, that occurs at the same time as ventricular contraction. So it's going to be masked. So the atria relax while the ventricles contract. So really the QRS is a combination of atrial repolarization and ventricular depolarization. Most people say that really the QRS is from the ventricles, but there's got to be some contribution from the atria relaxing that you're not, of course you're not going to see that separately on there. It's going to show up as one single complex. Then the T wave is strictly ventricular repolarization. When the ventricles repolarize, they also relax because the calcium has left. Right? Remember, the muscle contraction and relaxation itself is from calcium either going in or out, whereas the EKG tracing, any wave on the EKG is from, it could be any particular, really, not particularly, but technically any ion, if it were getting into the cell, making it more positive, or going out of the cell, right, that would create a voltage or a current, I should say, and that would basically give you a wave. So, but what I want you to become familiar with is what are the major ions that are flowing at each step, and more importantly, in this case, where what part of the heart is relaxing, or I should say depolarizing or repolarizing at each point. And unfortunately, some of these intervals, the way they're named, can be a little strange because the PR interval is actually from the beginning of the P wave to the beginning of the Q, which is part of the QRS complex. It doesn't actually go all the way to the R, which is strange, but that's the convention. The QT interval yeah, it's from the Q all the way to the end of the T. The ST is from the S all the way to the end of the T. And all these intervals are measured automatically by software that can basically tell you, raise a red flag. Like if the QT interval is prolonged, there's a risk for a certain arrhythmia called torsades that we'll talk about. So we always want to look, particularly as a pharmacist, are there any drugs that could cause these intervals to change? And if a patient is on these drugs, does the EKG show that we're still in the safe range, right? That the drug is not at a toxic level causing, for example, QT prolongation. So we already talked about the intervals, but to actually describe what they represent, you see that here. The PR interval is from the start of atrial depolarization to the start of the QRS. The QT interval is from ventricular depolarization to ventricular repolarization. So that means, right, the QT interval is, from the Q to the end of the T, but also this whole flat point here, right? That's when the ventricles are still contracted and they're sustaining that, and they're stuck at a very strong contraction, almost like a plateau of contraction. They're sustaining, and because the current is not right, really the ions aren't flowing at that point. Or they're basically the voltage is not changing at that point at the maximum contraction. You're not going to see anything on the EKG until the ventricles finally repolarize and they get rid of their potassium, and then the calcium channels close. So as the potassium rushes out, you're going to see that you're going to get the T wave, okay, as the ventricles repolarize. And again, QT prolongation is the most common drug-induced EKG abnormality. So none of these are going to be test material, right? So these are FYI. But sometimes they're interesting, and some of you might have experienced these yourself or in a family member. There's a lot of different things. I mean, really, there's like an infinite number of abnormalities, but we can look at some interesting ones here. Premature atrial contractions can occur, and and that's why we need to know what part of the EKG represents the atrial depolarization. So that's the P wave. So we have a P wave, QRST, P, QRST, but then we had an early P, right? Early P wave, so that would be a premature atrial contraction. But notice the QRS and the T, they follow it normally, like just the normal pattern. So that tells you very quickly, right, that the ventricles are going to be dominated by that atrial signal, right? So that the atria contracted early, so that means the ventricles depolarized or contracted early, right? So in many cases, that's what's going to happen. The ventricles will just follow what the atria are doing. Another one is paroxysmal, which is sudden atrial tachycardia. So we go from a normal rate to all of a sudden very, very fast. And if you have atrial tachycardia, remember that will translate into ventricular tachycardia because it goes right through the AV node. Atrial fibrillation, excuse me, anytime you have fibrillation, that means the muscle tissue is not contracting in synchrony or together. That means, one muscle fiber will contract at a different time than another muscle fiber. So the atria are not contracting together. So instead of seeing a single wave, you're seeing a bunch of kind of basically sloppy waves. The really cool phenomenon is that because the AV node is like an insulator or again, that's like that bottleneck, what'll happen is even though we have these like constant atrial signals coming, the AV node will only allow those to flow through the node every so often, right? It won't allow every signal to go through. It's kind of like a filter. So it's the AV node says, well, okay, you're too early, you're too early, you're too early, and then it says, okay, I'll let you go through, and then it goes to the ventricles, and then it'll happen over and over again. So we're fortunate because the ventricles are somewhat protected from atrial chaos, right? So if someone has AFib, they may not even know that, although it is a problem because it can cause blood clots or embolisms. But AFib is not something you normally would, sometimes you wouldn't even feel that as, like, oh, my heart is racing, or I have, uh, you know, fatigue because the blood isn't flowing out of the heart very well. You may not even notice any of that, but because the atria are not fully contracting, you can get stagnant blood and blood clots in there. And you're going to see in the cardio module that one of the mainstays of treatment for AFib is actually anticoagulants. Some people call those blood thinners, right? But moving on, premature ventricular contractions are pretty darn common. So if you ever feel like your heart skips a beat, again, I've known people, several people have had this. You have the P, QRST, and then you get all of a sudden you get a ventricular contraction before the atria, right? So for some reason this is quite common, like I said, but what'll happen is because the ventricle contracted actually early, what it's going to feel like is that almost like a skipped beat, because then between that contraction and the next one, it's going to be a delay. Okay, and that's again PVCs. Standard VTach would be, again, the ventricles having a normal frequency. I shouldn't say normal, but a regular, meaning a consistent spacing, right, by time, right? So the rhythm will be consistent, but it'll be very, very fast, and that's tachycardia. And that can happen from caffeine excess. Of course, when you're running, that's a normal situation to have. It wouldn't really be tachycardia because it's expected. But if you were having a heart rate above 100 at rest, that would be tachycardia. VFib is of course very fatal because the ventricles are the most important chambers for moving blood forward. And what you'll see in the EKG with VFib is just kind of like randomness, and that means the ventricles never get a full contraction at the same time. So different parts of the ventricular muscle will contract at different times. So it'll look like, some people say, a bag of worms, because it'll be like writhing in like a wave-like action, and it won't be coming all together at once to move the blood in a productive way. So we talked about all the nodal tissue, and we definitely talked a lot about muscle tissue, but now we're going to finally start getting into the muscle tissue more specifically, and particularly the action potentials in muscle tissue. Remember how I said you should be able to easily identify an action potential in nodal tissue versus muscle tissue, and this is going to hopefully make that clear how you can do that. So the atria and the ventricles contain primarily contractile cells. So all that means is the majority of the heart mass is muscle tissue. In the ventricles, the Purkinje fibers distribute the stimulus to the contractile cells. Okay, so remember the Purkinje fibers allow the action potential to distribute kind of uniformly in both ventricles at the same time. This is FYI in terms of the numbers, but the resting potential of a ventricular muscle cell is about negative 90 millivolts. Atrial muscle is about negative 80. So they're both pretty similar. So they have to be, negative relative to the extracellular space. Again, the intracellular space is negative. So probably pretty obvious, but I like to reiterate this a few times because it's very easy to think about a muscle cell or a nodal cell in isolation, doing its own thing. But again, I think it's really important to constantly think about this, that any cell in the heart is directly connected to the adjacent cells. And this is just a reminder that that happens through gap junctions. So nodal tissue is connected to muscle tissue through gap junctions. And all that, in a very simple way, all that means is that when the cations come in because of a channel that's open, some of those cations could in an unrestricted way, very easily flow into the next cell, which may happen to be a muscle cell. So that means, again, anytime a nodal cell is activated, right, eventually that should result in muscle cells being activated either immediately because they're adjacent, or right through another nodal cell in that pathway. So they're basically all connected through gap junctions. Okay, and there, believe it or not, so I won't get into it now, but there are drugs that appear to affect gap junction function. And sometimes that's useful if someone has a cardiac arrhythmia. So this is what I was referring to. Please make note of the top here, top right. That is the cardiac muscle cell action potential. And I always know that immediately because of the spike at the top left. Okay, so this spike here is characteristic of the muscle cell, and the slope is much more prominent than what you'd see in a nodal cell. Remember, the nodal cell would be a little mound, right, with a very smooth top, whereas the muscle cell is a spike and then almost a plateau there. In fact, they call that the plateau phase. So please, first of all, be able to recognize the difference. And then again, secondly, please understand what ions are important for what components of the action potential. The first one I want to point out immediately that is different between muscle and nodal tissue is that in muscle tissue here, the main ion flowing in during this upward slope is sodium. In nodal tissue, the main ion flowing in during this upward slope is calcium. So that means calcium is critical for depolarization in nodal tissue, whereas in muscle tissue, the main purpose of calcium is just for contraction, right? Whereas the main purpose of sodium and then is for the depolarization. So let's go in order here. So first, cations from nodal cells leak into the muscle cells to trigger fast sodium channel opening, which is the sharp upward slope. The L type, which is the voltage-dependent calcium channels, open to create the plateau phase when contraction occurs. So again, it's very easy to mix up, but the calcium in the nodal tissue during that upward slope at the beginning is the same type of channel. It's called the L-type calcium channel. That's the same channel as the one in the muscle tissue that's responsible for this plateau phase. So again, if it were nodal, that upward slope would be a little less prominent, but that would be the calcium. But in muscle, the calcium is primarily in this plateau phase, right? And that's, again, critical for the contraction. Finally, the calcium channels will close based on a certain amount of time, and they're time dependent. And potassium efflux brings the muscle cell back to resting potential. Okay, if you forget which way the ions flow, but you remember, where are the ions normally concentrated, then that'll be pretty easy, right? So the ions like to flow down their concentration gradient, so where they are less abundant. So remember, sodium is always abundant outside the cell. So when you open up the channel, it flows in. Calcium is also very abundant outside the cell. When you open up calcium channels, it flows in. Potassium is abundant inside the cell because of the sodium potassium ATPase pump. You open up the potassium channels, it flows out very rapidly. So that will help you to, without really memorizing that, all these, you can kind of predict which way they're going to go. And again, on the bottom, just like before, the bottom is the permeability of different ions at different times. Again, the bottom doesn't tell you what direction they're going in, but it tells you how fast they are going or what the permeability is, right? So please, really, I want you to commit all this to memory. That's only because the drugs that you're going to learn about later on in the curriculum directly affect most of these channels. So this slide just kind of reiterates what we just talked about. I don't want to get into again what the ions are doing again right now, but what I wanted to add here is the term again called the refractory period, which I did allude to that earlier. But this is really important, especially when it comes to understanding the medications later. So the refractory period is when, in this case, we're particularly talking about the sodium channels, when they're activated, but then, as soon as the sodium channels get activated, sodium rushes in, and then immediately at this spike up here, the sodium channels become inactive and also refractory, meaning they're going to ignore any further action potentials or stimuli. So during this whole absolute refractory period, you could no longer activate that cell, right? That cell is going to ignore another stimulus. And that's why I said, remember, the cardiac muscle is hardwired or engineered to avoid a tetanic event where they can have tetany, like your skeletal muscle, right? We want to avoid tetany because you need the heart to relax after each beat. And this is exactly why that happens. And that's because the sodium channels shut off, they deactivate, and they just ignore any signal, right? Until they get through the absolute refractory period. And then the relative refractory period is where some sodium channels are recovering. Okay, some of them have not recovered. And then at the end of that, we have full recovery. So then any sodium channel at that point can, if it receives another signal, it will open up again and let the sodium flow in. And by signal, right, it always means the same thing. It means cations flowing in from a gap junction. So it always means the same thing, right? So that's some simple things we can generalize and keep in our memory, that there's not there shouldn't be too much of a kind of an enigma here or mystery, right? It's always the same thing. Cations flowing through gap junctions, activating channels that are dependent, or they're voltage dependent, or responding to those cations that change the voltage, right? So it's very similar probably to what you had in the last semester as well. So this is a really helpful diagram showing you skeletal muscle versus cardiac muscle. And I think the most important point to look at is that um, how refractory are the channels during what point in the contraction. So in skeletal muscle, notice at the peak of contraction, right, the highest force, we've already moved past the point where we're refractory, so we're no longer refractory. That means at the highest contraction, those channels could be reactivated again immediately. So you should be able to sustain that contraction as long as you have the energy, right, the willpower, but also like the actual energy stores, right, and oxygen. Whereas, well, it depends if it's anaerobic, right? We won't get into that. Whereas a cardiac muscle, notice at the peak of contraction, we're right in the middle of the refractory period. That means sodium channels can no longer be activated, right? And if the sodium channels can't be activated, remember, then the calcium channels can't be activated because those are activated by voltage, right? So again, the sodium channels have to fire or open first, and then that rapid rise in voltage will then open the calcium channels. Well, none of that can occur during the refractory period in a healthy heart, right? And some pathologies can occur that would overcome this rule that we have here. So then we're pretty much almost done with our contraction by the time the cardiac muscle is ready to receive another stimulus to contract again. So it's engineered to allow that relaxation to occur. It's required to occur before, right, we get another response to the next action potential. So this gets into more on the absolute versus relative refractory period. I don't want you to commit this to memory, but again, absolute means there's absolutely no response to another action potential, whereas relative means literally what it means is some of the sodium channels have gone back to resting and they can be activated again, and some of them have not. So the relative refractory period is a short period of time where, again, some channels are ready, some of them are not, and you can get a stronger um, voltage change depending on how strong the stimulus is, or how many cations are flowing in from gap junctions. Not too much to memorize there. Okay, in terms of the timing of refractory periods, the length of cardiac action potential in ventricular cells is 250 to 300 milliseconds. This is FYI, but that's 30 times longer than the skeletal muscle fiber. The only thing I want you to know is, we've said multiple times, that the refractory period in the cardiac muscle is much longer, and that prevents a tetanic contraction. Right, that's the main point. So the next discussion point here in this lecture is excitation contraction coupling, meaning, and this is somewhat of a review because you've had this with skeletal muscle. So how does calcium cause contraction, and how is it regulated? And the regulation is very important because most of the drugs you're going to learn about related to affecting heart rate later on, and the heart in general, most of those will affect directly or indirectly, they'll affect calcium, right? So how is that regulated? How much calcium gets into the cells and how much is getting out, and that kind of thing, and that's what we're going to talk about now. So I have a feeling a lot of this will be review, Okay, so I'm going to go through it a little bit quickly, and I will hold you responsible for the main points here, particularly what's in bold or anything else that I emphasize. So the flow of calcium in cardiomyocytes. Remember, cardiomyocytes require calcium influx through the L-type calcium channels. There's a wide T-tubule system that facilitates calcium diffusion from the extracellular fluid. And remember, the T-tubules are invaginations or indents, kind of that allow the calcium channels on that membrane to be pretty close to the sarcoplasmic reticulum. It puts them within that vicinity. And then you have something called calcium-induced calcium release. So when the calcium comes in from the L-type calcium channels, that's from extracellular to intracellular, that is going to activate the ryanodine receptor on the SR or sarcoplasmic reticulum. So that's another calcium channel. So then remember, more calcium comes from the SR. That also enters a cytosol. So then you have two different sources of cytosolic calcium. That calcium causes cardiomyocyte contraction. The SERCA pump, which is the sarcoendoplasmic reticulum calcium ATPase pump, that brings calcium back into the SR to allow cardiomyocyte relaxation. So it's important to understand, first of all, where the calcium comes from, what channels. So the L-type calcium channel, then the ryanodine receptor, and then how does the calcium leave? And the SERCA pump is only one way by which it leaves. There are also calcium channels that pump calcium into the extracellular space, so not just the SR. There's a regulatory protein called phospholamban that is directly attached to the SERCA pump. The phosphorylation status of phospholamban determines how it affects SERCA. So if phospholamban has very little phosphorylation, that equals lesser SERCA activity. So another way of looking at that is, I look at phospholamban as a regulator or governor of SERCA. So when phospholamban is active or not phosphorylated, it suppresses SERCA, and that slows down the relaxation phase. So what you'll see is it actually takes longer for the heart to relax. That will be a good example of what would happen when you give someone a beta blocker like propranolol or metoprolol or something like that. That would be due to less phosphorylation of phospholamban. High phosphorylation of phospholamban would be it would relieve the suppression of the SERCA pump, so it would allow the SERCA to pump more actively. And what would cause that, something like that, would be like norepinephrine or epinephrine, which is just noradrenaline and adrenaline, activating the beta-1 receptor on the plasma membrane. That would ultimately result in phospholamban phosphorylation and greater SERCA activity, therefore a faster relaxation. Again, so that means when you're having a lot of adrenaline, your heart will relax faster and it'll contract faster, right? The entire cycle is faster. So please understand that phospholamban normally suppresses SERCA unless phospholamban is phosphorylated. So we put this all together here, and I apologize if some of the abbreviations are not obvious, but DHPR is the same thing as the L-type calcium channel. That's the dihydropyridine receptor because it responds to dihydropyridine calcium channel blockers. Again, that's the same as the L-type calcium channel. Okay, so remember that allows calcium to go in. That calcium is pretty close to the ryanodine receptor that's activated. That allows calcium to flow out of the SR, also into the cytosol. That causes contraction, and I won't get into the actin-myosin interaction here because you've had that, but that causes contraction. Eventually, after the contraction, the calcium has to leave and go into the, basically going into the SR. SERCA does that. Okay, and that's just showing you there are different types of SERCA, but that doesn't matter here. SERCA does that. Phospholamban regulates that. If we phosphorylate it, we relieve that inhibition, so this is faster. If we don't phosphorylate phospholamban, this is going to be slower, so the relaxation will be slower. So all this is directly affected by this beta receptor, beta in this case beta 1. So if you activate beta 1, that the long story short is that phosphorylates phospholamban, and that increases relaxation. That also phosphorylates other things which you're actually not seeing here, but that would phosphorylate the L-type calcium channel and the ranitidine receptor. So when you activate the beta 1 receptor, the real easy generalization to remember here is that activate that beta 1 receptor with things like epinephrine and norepinephrine, that accelerates the L-type calcium channel, it accelerates the ranitidine receptor, and it accelerates calcium removal afterwards into the SR. And the fourth one is actually it accelerates calcium removal all the way outside the cell, from the inside to the outside. And this is the plasma membrane calcium ATPase. Okay, so in general, then, if you think about it, adrenaline or epinephrine and norepinephrine will accelerate every component of the cardiac cycle, right? Faster and stronger contraction and a faster relaxation. So this is kind of summarizing a lot of that. So the contractile force is directly related to how much calcium is in the cytosol. Okay, so drugs can regulate that. Drugs can also alter this calcium sensitivity of the regulatory proteins. Okay, so the main point though is that, right, so what regulates the calcium flow, and that's primarily the beta 1 receptor in the phosphorylation events. Norepinephrine, again, please remember, that's from the sympathetic nervous system that activates beta 1 receptors. You don't really need to know right now about cyclic AMP, but that is part of the pathway. Please understand the ultimate outcome, which is the phosphorylation events, which results in that accelerated calcium movement, first inside the cytosol and then out of the cytosol after that. Do this with most of these topics in this course, just a few clinical issues, just to make it more interesting and talk about some of the things that can go wrong. So with the heart, we can get arrhythmias, which are the uncoordinated atrial and ventricular contractions caused by a defect in the conduction system. We already went over a few examples of those, like atrial fibrillation, PVCs, etc. Fibrillation is a rapid and irregular contraction where the SA node is no longer controlling the heart rate. AFib, as I mentioned once, can cause clotting and inefficient filling of the ventricles. VFib is actually much more life-threatening on an acute phase. It means like immediately, whereas AFib can be life-threatening if you develop a clot, right? That's the main reason why that's a problem, right? And that can take weeks or years depending on the patient, whereas the VFib is going to be life-threatening immediately. Defibrillation is the application of an electrical stimulus to shock the heart back into a normal SA or sinoatrial rhythm. Sometimes people get pacemakers implanted, and that is different from a defibrillator. A pacemaker is a device that delivers the electrical stimulus rather than the SA node, and that means if your SA node is not giving a productive rhythm, right, the SA node is not firing at a productive rate, they can install a pacemaker to force your heart to beat at a certain rate, or at least to avoid bradycardia, right, to avoid a very slow heart rate. Again, pacemakers are very different from defibrillators. However, people have, right, for many, many years, probably decades, um, internal defibrillators have existed. So there are patients that have defibrillators already in their body connected to the heart. And that would be a patient that gets a lot of fibrillation events where the heart's not contracting in synchrony. So that'll defibrillate them automatically. Okay, so you don't need to have a first responder there. So again, that's also very different from a pacemaker. So defibrillators and pacemakers are the only thing about them that's similar is that they're both stimulating the heart one way or the other. Again, this is kind of a reminder, an ectopic focus, just like, and again, I always use this example because it's probably the most common one. An ectopic pregnancy is when a fetus is developing, usually in the fallopian tube or not in the uterus. An ectopic focus is the same idea. It's just we're talking about the electrical stimulus. It's in the wrong location, right? It's an abnormal pacemaker that takes over the conduction system faster than the SA node, but it's typically in the muscle tissue somewhere like the ventricular muscle, the atrial muscle, and that should not happen normally. Remember, if the SA node is damaged through a heart attack and that tissue is dead, the AV node will take over. And that's okay for normal circulation. It's not ideal, but it's okay. Premature contraction is also called an extrasystole. The PVCs are the most problematic, and I say they're one of the most common actually. So some people live with those without any problems, to be honest with you. For some people, it just happens sporadically and not too frequently. Something that I've always found interesting personally is that there's something called heart block, which typically means AV nodal block. So if the AV node is not conducting correctly due to tissue damage or some other reason, maybe electrolyte abnormalities, you no longer have communication between the atria and the ventricles. And the most interesting one is probably total block, because that means the atria have their own rhythm or rate, and then the ventricles have their own rate. So it'll look like two people beating on a drum at a totally different pace, right? So the atria beats their own, the drum goes at its own beat, right? The ventricles have their own beat, and they're totally unrelated. So it's very easy to see on an EKG because sometimes the QRS will be right on top of the P wave, and then it'll break away from it because it's eventually the beat escapes, and they're not on top of each other. So they'll just be totally out of sync. And then I mentioned earlier that the unilateral bundle of His block, or one-sided block, is really interesting because then you see actually two QRSs. It's very easy to identify that actually. Again, most of these abnormalities are pretty obvious on an electrocardiogram. So now that we talked about basic anatomy of the heart, we talked about the conduction system and regulation of the heart rate. I'd like to kind of formally get into the cardiac cycle, even though we've had to talk about it several times already. The cardiac cycle is the period between the start of one heartbeat and the beginning of the next heartbeat, and includes both contraction and relaxation. The two phases of the cardiac cycle this could be within any chamber, is systole and diastole. So this could be in the atria, so that would be atrial systole, or the ventricle, which would be ventricular systole. Just so you know, the convention is if someone just says systole on its own, they're generally referring to the ventricles because those are what generate the pulse. So systole, again, contraction, diastole, relaxation. So on this diagram, you'll see the entire cardiac cycle, and I do have multiple versions of this coming up. One of them is going to be broken down in a little bit simpler. This one's kind of the full cycle in one image. So hopefully one of those will be more useful for you than another, and I hope you find one that works well for you. So the starting point, which really could be anywhere, but the starting point here is with atrial systole. So first of all, I wanted to point out that the ventricles will fill up with blood kind of passively This would be blood coming from the inferior vena cava, superior vena cava on the right side. On the left side, we have the two pulmonary veins here, and then the two pulmonary veins hidden behind here. So the blood is going in passively, but at the end of that, the atria will eventually contract to push a little bit more blood in. So the majority of the blood in the ventricles comes from passive flow, and then again, there's that bonus thing called the atrial kick, with the last bit of blood goes in. So atrial systole will then end, and then atrial diastole begins. So the atria start to relax, but then this is this very kind of interesting phase where the ventricles just start to contract just in the beginning here. So the first phase here of ventricular systole, that the ventricles are just starting to build up pressure, right? And what will happen is kind of interesting is that it's enough pressure to close the AV valves, but it's not enough pressure to open the semilunar valves. So this is a very, very short period of time. It's called an isovolumetric contraction because the blood volume is not changing in any of the chambers at this point. Okay, particularly in the ventricles, the blood volume is not changing. And that's because all the valves are closed for a very short period of time. So as soon as the ventricle develops enough pressure to exceed the pressure in the aorta and the pulmonary trunk, right? So each ventricle respectively will do that. Then finally, we look down here, then again, the aortic valve will open and the pulmonic valve will open. The entire time, the AV valves are still closed as long as the ventricular pressure, the blood pressure there is higher than the blood pressure in the atria, right? So the entire thing is based on pressure gradients. Okay, so we've already bypassed the isovolumetric phase. Now we're actually moving blood forward into the major vessels, the major arteries. Finally, we have ventricular diastole. Okay, as ventricles relax, pressure in the ventricles drops. Okay, blood flows back against the cusps of the semilunar valves and forces them closed. So we're at another point where all the valves are closed because the pressure at this point in the ventricles is lower than the pressure in the aorta and the pulmonary trunk, but slightly higher than the pressure in the atria, right? So enough to close the AV valves or to keep them closed, but the pressure is too low to keep the aortic valve and the pulmonary valve open. So these are all closed at this point. So this is our second isovolumetric phase. This is isovolumetric relaxation because the ventricles are starting to relax. The first one was isovolumetric contraction. And that's, again, you're going to see really soon how long that is. It's very brief. And again, you'll see it on a more involved diagram that shows everything, the heart sounds and everything else in the heart, whereas this one's a little bit more basic. So then you move on, and then you have the late ventricular relaxation or diastole. All the chambers are relaxed and ventricles fill passively. So at this point, the ventricular pressure must be lower than the atrial pressure. It's low enough to open the AV valves and blood will passively flow in, right? And the rule of thumb is that, right, as long as the pressure in the aorta and the pulmonary trunk is higher than the pressure in the ventricles, those valves will be closed, right? The AV valve, or sorry, the pulmonic valve and the aortic valve will be closed. And then that's it. It repeats over and over again, right? So at the very end of, right, the filling period where the ventricles are filling during that diastole, the very end, the atrial will finally contract again to kick a little bit more blood in there, and then we'll repeat over and over again. So the next two slides are going to break down the cardiac cycle into diastole and systole, kind of a simple manner. So if you look on the left here, again, isovolumetric ventricular relaxation is when the ventricles are relaxing, but all the valves are closed. Okay, so they're just starting to relax. So that would mean, you should be able to kind of guess this at this point that, where's the pressure higher and where is it lower? So the pressure in the ventricles would be higher than the pressure in the atria, but the pressure in the ventricles is lower than the pressure in the major arteries, which would be again the aorta and the pulmonary trunk. So that's a very short period of time, kind of milliseconds. And then what'll happen is pretty soon after that, the pressure is low enough as the ventricles relax even more. The pressure becomes low enough to open up the AV valves, which happens simultaneously on both sides. Blood passively flows in to the ventricles from the atria, and the entire time the semilunar valves are closed. Okay, and then at the very end of diastole, the atria finally contract a little bit, and that's the atrial kick, where we push a little bit, maybe 20% more blood into the ventricles, and that'll conclude the diastolic phase. And then we get to systole. In the very beginning of systole, remember, all the valves are closed again, because when the ventricles just start to contract, that will close the AV valves, but it's not enough pressure to open the semilunar valves yet, right? So that's, again, a very, very short period of time. And then finally, when the ventricles contract a little bit more, they will open up the semilunar valves, and the AV valves will remain closed, so the blood should flow in only in one direction. So I believe this video is actually working in the PowerPoint recording, so I'm going to go ahead and try it, but this is just kind of a summary of the cardiac cycle.
The heart is a muscle pump that propels blood simultaneously through the pulmonary circuit of the lungs and the systemic circuit of the rest of the body. Beginning while the heart is in a relaxed state called diastole, blood enters the heart at the atria. Blood is then ejected from the heart when the ventricles contract, a state called ventricular systole. This alternating sequence of systole and diastole is called the cardiac cycle. A complete cardiac cycle is fairly rapid, taking less than 1 second to complete. The cardiac cycle can be graphically represented by plotting ventricular volume against time. Volume changes are the same for the left and right ventricles, so for simplicity, only the left ventricular volume is shown. The left ventricular volume increases during ventricular diastole as the ventricle fills with blood, both here and here. Ventricular volume decreases during ventricular systole as the heart muscle contracts and blood is expelled into the aorta. The graph begins about midway through ventricular diastole, where the ventricle is moderately full of blood. The atrioventricular valve, or AV valve, is open, and blood flows passively from the left atrium to the left ventricle. During this time, both the atrium and ventricle are in diastole. The one-way nature of the semilunar valve, now closed, prevents blood from entering the relaxed ventricle from the higher pressure in the aorta. Toward the end of ventricular diastole, the left atrium contracts, causing a surge of blood to enter the left ventricle. This event is called atrial systole, which accounts for about 30% of ventricular filling. The ventricle now contains its maximum volume of blood, or end diastolic volume. Atria, now at rest, become diastolic again. As ventricular systole begins, pressure inside the contracting ventricle caused the AV valve to close. And for a brief period of time, the aortic semilunar valve also remains closed. This portion of ventricular systole is known as isovolumetric contraction, a period where the ventricular volume remains constant even though the heart muscle is contracting. As systole continues, the ventricle develops enough pressure to push open the aortic semilunar valve. Blood rushes out of the left ventricle and into the aorta. This is called ventricular ejection. Ejection from the ventricle is reflected in the graph as a decrease in left ventricular blood volume. Eventually, at the end of ventricular systole, the ventricle contains its minimum amount of blood, called the end systolic volume. Ventricular diastole begins when the ventricle begins to relax, closing the semilunar valve. But as with the beginning of ventricular systole, ventricular diastole begins with an isovolumetric phase. For a brief period of time, ventricular pressure is low enough that the semilunar valve remains closed, but not low enough for the AV valve to be open. This portion of ventricular diastole is known as isovolumetric relaxation, a period where no blood enters nor leaves the ventricle. As ventricular diastole continues, once ventricular pressure decreases below atrial pressure, the AV valve opens and the volume of blood that had been accumulating in the atrium flows from the atrium into the ventricle. Then blood continues to fill the ventricle as it simply flows from the pulmonary veins through the atria and into the ventricle, filling it up like a water balloon. This passive process accounts for the majority of ventricular filling. With the ventricle now moderately filled, we've come back to where we started. This marks the end of one cardiac cycle. Further along the graph, volume changes associated with the next atrial systole is evident. The next atrial systole belongs to the next cardiac cycle. In summary, the cardiac cycle is a series of contraction and relaxation phases called systole and diastole that open and close one-way valves to move blood into the systemic and pulmonary circuits. We focused on the left side of the heart, but events on the right side are similar and occur simultaneously. In general, blood flows from the veins into the atrium, then through the AV valve into the ventricle, then through the semilunar valve and into the arteries. On the volume graph, we began with blood filling the left ventricle during ventricular diastole. This is a period that includes atrial systole that serves to top off the ventricle. Once filled, the ventricle contracts, entering ventricular systole, where the AV valve closes. The semilunar valve opens and the blood is ejected from the ventricles into the aorta. The ventricle then begins to relax, entering ventricular diastole, where the semilunar valves close. The AV valves open and the ventricle begins to fill again in preparation for the next cardiac cycle.
So this slide is actually an interactive, I believe it's a flash video or flash animation, and unfortunately I don't think when you download the PowerPoint from D2L, I don't know that you'll be able to get this to work on any newer version of PowerPoint. I can help you do that. I got it to work because you can edit the registry of your computer, and again, I didn't want anyone to have to mess around and potentially mess up their computer. So it means you can't probably do it on your own. So what I wanted to do is go through it, at least from my perspective on my computer, and show you basically the entire cardiac cycle, and go, rather than just a still image, we can actually show you like at what point we are on this graph and then looking mechanically what is happening to the heart. Unfortunately, I just realized that, and I probably mentioned this in the past too, but sometimes I forget, but this chamber is actually looking like the right side of the heart, whereas the pressures generated in this diagram are pressures that would be in the left side of the heart. So I think there's a big mistake here. What I don't want you to do is focus too much on what side of the heart we're looking at. I want you to understand that this happens in both sides, except the pressures are going to be different. Okay, but it will happen simultaneously. So imagine if we were, again, in the left side, even though this is not, the blood would have to go through the AV valve, and then that would shut, and then the blood would have to go through the aortic valve, and then go to the aorta. So why don't I go ahead and click the next button. What we see is, right, that's going to keep going. So we can pause at any time, right? We can pause it at any time. So let me go back for a second here, start again. So what's happening is, and you got to help yourselves out in something like this. So, what would help you to figure out where we should be on this diagram at this point? So this is showing me, well, the ventricle is filling, right? The ventricle is filling with blood. So on the diagram, we should be in the filling phase, which is diastole, which is, right, this is the left ventricular blood volume on the bottom, this kind of brown curve on the bottom. And what happens is this is going to fill up with blood, fill up with blood, fill up with blood, the brown spot there. And my pointer's not going to work on this because of the way I'm doing it on Zoom. But what happens is when you get to the at the end of the filling phase, the atria will contract, and you get that little jump on the brown curve, or brown or red on the bottom, and then that's, you're talking about then your end diastolic volume. And then as soon as the heart is totally filled with as much as it's going to be, the ventricle should start contracting. That should be, again, this very narrow window where you have the first heart sound. That should be the isovolumetric contraction phase, where the ventricular pressure is, it's going to be above the atrial pressure, and that's going to slam the AV valve shut, but it's going to be below the aortic pressure. So you're going to be this very short period of time where all the valves are closed, and then soon enough, the pressure is high enough to open up the aortic valve, so the ventricular pressure exceeds the aortic pressure. So that's when you should see the valve open, that aortic valve there, and there it goes, right there. And then it will close again, right? The aortic valve will close when the ventricular pressure drops below the aortic pressure, right? So every single step in this is based on pressure differences. So ventricular pressure is low, then, lower than aortic, the aortic valve closes, and that's what you'll see here. That's the second heart sound where it's green there, where it's active. So you should understand, putting this all together, it's actually a lot easier than looking at one thing, I think, looking at one step. So you could look at the heart sounds to tell you, oh, the AV, the AV valve, the first heart sound should be closing. The semilunar valves should be closing in the second heart sound. So that would help you like understand what else is happening. So if the AV valves are closing first, you should be able to guess what else is going on in the heart. That means the ventricles are forcing them shut. So the ventricles must be generating a lot of pressure, and that's what you see here. The purple, kind of purple tracing, left ventricular pressure is rising, and that's going to force the AV valve shut. So what I want you to do is kind of maybe do this on your own, maybe even draw it out. That would be the absolute best way to study for this kind of thing, is to start with a blank slate, and just at least, you should know what the axes should be labeled, and maybe you can use, at least write that down ahead of time on the chart, the axes. But then other than that, I want you to be able to draw this just for practice. On a test, I'm not going to ask you to draw it, but I'm going to ask you what is happening at each step, what valves are opening or closing, etc. So sorry, I kind of skipped the end here. So let me let it go again. So again, filling up, then contracting, aortic valve opened, blood is leaving, aortic valve closes, blood is coming back in, right? And it repeats and repeats and repeats. Okay, and that's the entire cycle. So hopefully this helps a little bit for you guys to get familiar with it. Just some more basics on the cardiac cycle. The blood pressure clearly, or obviously in any chamber, would rise during systole within that chamber. If we're talking the atrial systole, of course, the blood pressure rises as the chamber volume gets smaller. It's putting pressure on that blood, and then it falls during diastole. Blood flows from high to low pressure in every case. That's really critical to understand. The only thing that would prevent that would be the valve closing. So, when the ventricular pressure is higher than the atrial pressure, the only thing preventing it from going backwards is that valve design. And that's, again, the high to low pressure is controlled by the timing of the contractions, and again, the one-way valves. So in terms of the cardiac cycle and heart rate, at about 75 beats per minute, the entire cardiac cycle lasts about 800 milliseconds, so it's less than a second. When the heart rate increases, all phases of the cardiac cycle shorten. As I mentioned, for example, if you have adrenaline, and that's what's going to cause the heart rate, right? The heart rate's going to increase because of epinephrine or norepinephrine. When you're active or nervous or have caffeine, right, that's going to cause the contraction to be quicker and the relaxation to be quicker. So the entire cycle is shortened, but diastole is particularly shortened, during, when you have a faster heart rate. So all the phases of the cardiac cycle together are atrial systole, atrial diastole, ventricular systole, and ventricular diastole. Again, this is just a little bit of a review with some new terminology. Atrial systole means atrial contraction begins. The right and left AV valves are open. Atria eject blood into the ventricles, filling them. Atrial systole ends. The AV valves close. Ventricles contain the maximum blood volume at the very end of atrial systole, and that's called the end diastolic volume. And that hopefully makes a lot of sense because it's self-explanatory. At the end of the relaxation phase, we're talking about ventricular diastole, right? The end of the ventricular diastole, that's called the end diastolic volume. That's the volume of blood in the ventricles at that point. So in ventricular systole, the ventricles contract and build pressure. The AV valves close. Remember, that starts with the isovolumetric contraction, and then it quickly will open up the aortic and pulmonic valves, or those semilunar valves, to move blood out. And that's called ventricular ejection. That's when the ventricular pressure exceeds the major artery pressure, opening those semilunar valves, allowing blood to leave the ventricle. The amount of blood or volume of blood ejected is called the stroke volume. So please be familiar with this terminology. The first one was the end diastolic volume, and now the stroke volume is very simple. Right? It's the amount of volume, the amount of blood leaving the heart upon one beat or one stroke. Then finally, at the end of systole, the ventricular pressure has to fall because the amount of blood in there is declining, right? So the pressure is lower, the fluid pressure is lower. The semilunar valves will then close, and there's no magic, there's no muscle doing that. There's no direct muscle in the valve, right? The only thing that's causing it to close is the blood is trying to go backwards because the pressure in the aorta and in pulmonic trunk will be higher than the pressure in the ventricles. So then, of course, we have another term called the end systolic volume. So at the end of systole, believe it or not, the ventricles still have a lot of blood in them. So about 40% of the end diastolic volume would be what would be the end systolic volume. So that means we only eject about 60% of the blood in the ventricles during each beat. So we have that it's called kind of basically a cardiac reserve. We have more blood in the heart in the ventricle than we necessarily would need. So the good thing about that is if someone becomes physically active, they have more blood in the heart that they could still eject, right, to compensate and to deliver that extra energy that they're going to need, the oxygen and the nutrients. So that's really important to have a little bit of blood left in the heart, actually quite a lot of blood left in the heart in a resting heart during each cycle. Now what we have here is really this is a portion of a diagram that's normally called the Wigger's diagram, and I'll have that in a few slides later. Everything will be combined where you generally would see ventricular pressure, atrial pressure, aortic pressure, left ventricular volume, and I'm going to include heart sounds in the EKG all in the same diagram, starting with this one here. So just so you know, this is in a number sequence. This only goes up to 5, and then we're going to get into the end point, which is really the end of ventricular systole. And then when we get into ventricular diastole, will be 6, 7, and 8 will be the last few numbers. So again, this is only half the diagram that we're going to start with. So what do we use this diagram for? And basically, the answer is that this diagram tells you what part of the cardiac cycle you're in. It basically tells you what the different pressures are in the different chambers and in the different blood vessels. And this diagram is typically the left side of the heart. The left side of the heart generates more pressure, and the left side of the heart is usually used for these diagrams. So we could really start anywhere, but what I want you to gain from this is to be able to look at something like this and tell me, what, for example, like if this were missing, this left AV valve closes, I'd like you to be able to tell me that that's when that is happening. where's the end diastolic volume? At what point where would you find that here? And that would be, of course, here. When does the aortic valve open? So be able to tell me these things, and if I cross these out or erase them, and the way you do that is by looking at, you know, so knowing like this is the left atrium, this is the left ventricle. So if you follow this along, and this is blood pressure in there, notice here the left ventricular pressure is lower. Only a little bit lower, but it's lower. So I think because of that, if the ventricular pressure is lower than the atrial blood pressure, blood should be allowed to flow into the ventricle from the atria. And if you go down here, you'll see that that's exactly what's happening. The left ventricular volume, blood volume, right, is going up because the ventricular pressure is lower than the atrial pressure, and blood could flow in that direction. What you're going to see here is this little kind of inflection point, and that's where the atria actually contract. Okay, so if you go far enough, you'll see basically when the ventricles start to contract, right? You can see here the beginning of ventricular systole. The ventricular pressure would rise above the atrial pressure, and remember the main event that's going to open or close a valve is pressure changes. So that when the ventricular pressure rises above the atrial pressure, the AV valve should close immediately, right? And that's the louder heart sound is when the valves close. Actually, yeah, like you really don't hear them opening. The heart sounds you should normally hear are when the valves are closing. So this would be, again, a pretty noticeable sound when you're listening to the heart. And then as it goes up, the pressure rises very rapidly. This entire phase here is the isovolumetric phase because the AV valve is closed, but the aortic valve is still closed as well during this whole phase. When you finally get a pressure higher than the aortic pressure, the aortic valve opens. And then even though this looks almost identical, because the left ventricular pressure is slightly higher than the aortic pressure, blood will flow out of the ventricle and into the aorta. Okay, and then right. So if you look here, the pressure in the ventricle is building and building and building because it's squeezing harder and harder. But eventually, it's going to get to the point where the blood volume is low enough that the pressure would drop in the ventricle, right? And then you reach this peak here, and then it's going to eventually start to, even in the middle of systole, the pressure can start to drop off because you're running out of that excess blood volume in the chamber. So again, if you go back down and say, well, how do I know just from, again, always look at the axis, just from the left ventricular blood volume, how can I tell when the ventricles are contracting or when that left ventricle is contracting? You can tell because when the left ventricle is contracting, very soon after that contraction begins, the blood volume should start to decrease because it should be going into the aorta, right? So I should look here and say, well, the left ventricle must have contracted pretty recently, and that would be shown as right at the beginning of systole, which is where the pressure first crosses over the left atrial pressure and then quickly will cross over the aortic pressure, right? So that's only part of the diagram, and again, like I said, we have the continuation coming in a few slides. So again, next is ventricular diastole. So that is when the ventricular pressure is higher than at the very beginning, right? In the very beginning of ventricular diastole, the ventricular pressure is higher than atrial pressure, and all heart valves are closed. That's isovolumetric relaxation. That's only a very short period of time that the valves are closed. Pretty soon after that, the atrial pressure becomes higher than the ventricular pressure, right? Because the ventricle is still relaxing. It's already removed a lot of its blood volume, but now it's expanding. So there's even more of a negative pressure developing. So what you find is that the passive flow of blood into the atria still generates higher pressure than the ventricle. So the AV valves would open, the atria fill passively, and then the ventricles fill passively as well. So again, this is the second half of the diagram. So at the end of systole, like I said, the pressure drops off, and then it's going to cross over when the ventricles start to relax. the pressure will continue to drop off as the ventricles relax, and we reach a point where the ventricular pressure drops below the aortic pressure, and that is where the aortic valve will close, and that'll be your second heart sound when the aortic valve closes and the pulmonary valve closes at the same time, right? So the AV valve's closing was the first heart sound. The semilunar valve's closing was the second heart sound, and then you keep going down, and this is all isovolumetric. All the valves are closed until we finally drop below atrial pressure, right? And then the left AV valve opens. The heart can start to fill again. As soon as the AV valve opens, blood will pour in from the atrium. It'll start to fill it up. And at the very end of that, again, we'll get that atrial contraction or systole, which will give you that little boost in left ventricular blood volume. So I want you to do your best to become familiar with these different phases of the cycle, and being able to tell me if I remove some of the names or the labels here, be able to tell me what those should be based on looking at everything else surrounding that. And this is putting that all together with two cycles basically. This is called it's really an old-fashioned diagram called the Wicker's diagram. You'll still see it in textbooks because it's still very useful and very accurate. And what you see is a combination of pressure in basically the left ventricle, and then volume again. So we already looked at both of these things, but then on top of that, the EKG and the heart sounds, right? The phonocardiogram. So I will give you this on the test, and I might remove a piece of it and say, well, where in this entire diagram does the AV valve close? Okay. And I'll say what I normally do is I'll label this window here as like A, this might be B, this would be, C, D, etc. And I'd say, well, or you should be able to say, well, at the end of A, the AV valve would close. But how would you know that? And the answer is, don't even look at the diagram when you're this is the way I do it. You don't have to look at the diagram right now, because first you have to think, well, what normally causes an AV valve to close? Well, that should be the ventricular pressure rising above the atrial pressure. So if you know that's the cause, where in this diagram does ventricular pressure rise above atrial pressure? And that label will be there. I'll keep the labels here on the test. And the red is ventricular pressure. The dotted line, black here, is atrial pressure. So you can see right here, there's a crossover where the red crosses over the black. That should immediately show you, really, kind of remind you or trigger it in your mind, oh yeah, the AV valve should be closing there because the pressure generated in the ventricle is higher at that point than the atrial pressure. So being able to use that whole thought process based on pressure differences throughout the entire diagram is going to be helpful. So I said, well, when is the aortic valve open? Without looking at the complicated diagram, you can say, well, the aortic valve always has to open when the ventricular pressure is strong enough to open it, right? When the ventricular pressure is stronger than the aortic blood vessel pressure, right? So that would be very evident on here. So here's the aortic pressure, that's the actual blood vessel, and the red is the ventricular pressure. So it crosses over right here. That should be, again, aortic valve opening. And you can help yourselves really, really nicely if you say, well, how do I know where the isovolumetric phases are? And guess what? This is actually even easier, even though the diagram looks more complicated. It helps you because by definition, isovolumetric means the blood volume is not changing in the ventricle. Well, guess what? We have a direct measurement of the blood volume here. So if you look at the flat point, right, you find that flat point, that has to be isovolumetric. Down here has to be isovolumetric because it's not changing blood volume. Okay, so I'm really going to ask you to do your best to use that information, right? The extra information that's here. So if you forget, one thing, you should be able to use that logic to say, well, maybe there's an answer somewhere else or information somewhere else that's going to help me answer this question. And then finally, if you just remember that the heart sounds are the valve closures, well, that'll help you too, because the first heart sound is always the AV valves closing, and the second heart sound is always the semilunar valves closing. We don't normally hear the third heart sound. Maybe a professionally trained cardiologist can probably do that easily, but normally you don't hear that very easily. Okay, and then like putting that all together and looking at the EKG, you should be able to understand at this point, right, that the QRS complex is happening when the ventricles have depolarized. That's ventricular depolarization, right? So ventricular depolarization occurs immediately before ventricular contraction. Basically, it triggers the ventricular contraction. So this, you should be able to tell that the QRS should be very close to, right, the beginning of ventricular systole. And we know this is ventricular systole because, well, it says it down there, but also because the ventricular pressure is starting to rise. So that means the ventricle must be contracting. So again, this is one of the more complicated things for some people, at least I thought it was for cardio. Some students, I think, pick it up a lot quicker than others. So I don't want to project and say that it's complicated for you, but if it is, please don't be alarmed, because I think it's a common issue that this diagram can be a little bit overwhelming depending on the way you're thinking about it and the way you learn. So the Wigger's diagram was really on the left side of the heart, but if we look at the other side of the heart, keep in mind the valves are opening and closing at the same time. The AV valves open and close together, the aortic and pulmonic valves open and close together. So that's all going to be at the same time. Okay, in both, again, both valves are responsible for the heart sound. So both AV valves produce the first sound, both aortic and pulmonic valves together produce a second heart sound. But I just wanted to briefly highlight the difference in pressure in the right side is that, again, the pulmonary artery has much lower pressure than the aorta. And when you think about aortic pressure, it's basically going to be your systolic pressure. So your systolic blood pressure, like normal or healthy would be like 120, right? 120, and then the diastolic will be about 80 millimeters of mercury. So the aorta is going to be close to 120, maybe a little higher than that, because you're measuring your pressure later down the pathway. So the highest pressure is in the aorta, but when you're looking at the pulmonary trunk, it's much lower because it's a much shorter circuit, right? The pulmonary circuit is much shorter. So again, that's the rule of thumb, that the less distance the blood has to travel in a circuit, the lower the pressure for any given flow rate or milliliters per minute. And remember, the left side and the right side have to pump the same volume of blood per minute. Otherwise, you're going to get an accumulation of fluid somewhere, right? If you can't move all the fluid forward that came from the right chamber into the lungs and then into the left chamber, or if they didn't move the same volume at this, per minute in each chamber, then you'd have a backup of the blood. And that's actually what happens in heart failure. So I just want you to understand from this slide that that the pulmonary pressure is a lot lower, but it follows the same mechanics, and that is that the right ventricle has to generate more pressure than the pulmonary artery or pulmonary trunk in order to open that pulmonic valve. And that's about it for that one. So I already talked about the heart sounds. I don't know that I actually told you the exact nomenclature. So the first heart sound is called S1. That's loud, and that's produced again by the AV valves. So you should know that the first heart sound is produced by the AV valves closing. And the very easy way to remember that, at least for me, is that remember when you close a door, it's a lot louder than when you open a door generally. So with the valve closures are going to be a lot louder than the valves opening. So again, S1 is AV valves closing, S2 is semilunar valves closing. Okay, so you should be able to tell me, like, when in the cardiac cycle does that happen? If you look back to the Wigger's diagram, it shows you, when the heart sounds are, and when would the AV valve close? When would the semilunar valves close? what would be causing that, right? And obviously, it's the pressure differences between the atria and the ventricles, and then respectively, then we're talking about the aorta or pulmonary trunk and in the ventricles. You don't need to worry or memorize these, but there's an S3 and an S4 that are typically not heard with a normal stethoscope. Okay, so soft sounds, that's blood flowing into the ventricles and atrial contraction. You might have heard of this when I was, and this is a very long time ago, obviously, but when I was in high school, before I joined football, before they allowed me to play, they tested every single player's heart for heart murmurs. Okay, and I didn't really know exactly what that meant at the time, but it's actually pretty simple. It means it's an abnormal sound, and it's typically because the blood is not flowing appropriately through the valves. It either could be flowing backwards or it could be flowing through a valve that's too narrow, even in the correct direction, and that would produce a different kind of sound, depending is it backwards or is it restricted. So that's considered a murmur. So again, that's the first clinical issue here. Actually, that's this entire slide is on murmurs. So again, it should be silent blood flow as long as it's smoothly flowing. If it hits anything that obstructs it, it will become turbulent, right? It'll swirl around, and anytime you have turbulence, that generates a sound that can be heard with a stethoscope. Most heart murmurs in adults are valve problems. The terminology here is that there's, first of all, there's something called an incompetent valve. That means it doesn't close all the way, doesn't close right, so the blood can go backwards. Okay. If the valve is stenotic, and by the way, stenosis means narrowing. It's narrow, and it's very easy to. A lot of people confuse that, and I think I did when I was a student. But sclerosis is hardening. Stenosis is narrowing. So we're talking about a stenotic valve, and it makes sense that that produces a high-pitched or clicking sound because the frequency, right, the turbulence and the frequency is high. So you're gonna, just like anything you're doing, if you have a sound and you narrow the passageway of a fluid, right, or air even, it'll raise the frequency, right? So it's pretty simple. So to look at it graphically, a normal valve will be on the top left. That is normal laminar flow. And remember, I'm imagining you've had all this, but in case you haven't, remember the fluid in the center of a tube always flows faster than the fluid near the walls because of friction on the walls. So that's called laminar flow. So it's kind of an infinite number of layers, but you can kind of imagine layers of fluid movement, and the layer in the center is fastest. So that's normal laminar flow. The stenotic valve is when it's narrowed and there's a lot of turbulence, and that's one type of murmur. And if you look at the bottom left, when the valve is closed, it should be silent, again, after it closes. But if you have a valvular insufficiency, okay, and I'm not going to ask you, honestly, all the terms here, insufficiency versus stenosis. You're going to need that later on in cardio, in the cardio module, at least some of that. Some of those terms you'll need to know, but basically right now, I just want you to understand that the cause of a murmur is the valvular abnormalities. And again, if it's an insufficient valve, that would cause leakiness. And remember, there's a lot of pressure trying to push the blood back into the atria. And if you imagine just imagine, even though obviously it's looking like we're in a tube here or a blood vessel, but just imagine this was in the heart, in the chamber of the heart. It's the same idea. As the blood is, being forced by the ventricle. It tries to go backwards into the atrium, and that should not happen. But if it does happen because of an insufficient valve, you should be able to hear that. A trained ear, right, should be able to hear that, and maybe even an untrained ear, honestly, because it should be loud. This slide is completely FYI, but I always find it interesting when when anyone's listening with the stethoscope for specific valve function. Like you can actually pinpoint a specific valvular abnormality or valvular sound based on where you place the stethoscope. So interestingly, so it's color coded. So look at the purple one there. It's very far away from, again, that would be the left AV valve. So placing it all the way down bottom left in the right in the middle of the rib cage there, that would actually allow you to kind of focus on the left AV valve, and so on and so forth. So just so you know, if a physician is doing that, whether on the back they're generally looking, listening for your lungs, but in the anterior of your body, they might be listening for valvular abnormalities. So the last section of this lecture is going to be cardiodynamics, and the next lecture will be on actual blood vessels and how they're regulated. So cardiodynamics is the movement and force generated by cardiac contractions. And just reading that, you might think, well, we probably covered all that already, right? But what we're actually going to cover is more terminology related to pressure differences, force, the forces in the heart. And some of it we've covered, some of it we haven't covered. So we're going to focus more formally on cardiodynamics now. The major terms that you need to be familiar with, and some of them you've already seen, are end diastolic volume, that's self-explanatory, and systolic volume, self-explanatory. Stroke volume, pretty much self-explanatory. Ejection fraction, again, pretty much something you can intuitively understand by just reading the term. Cardiac output, maybe not as obvious how that is defined until you see it. Preload and afterload, I have to warn you, for every single year that I've taught, for some reason, some of the most confusing terms have been this preload and afterload. Okay, so I try to spend as much time as I can kind of explaining them and giving different examples, but they are a little bit abstract. And preload and afterload can, they could be a volume or a force. And I'll tell you what they are right now, but then just because they're, again, I want you to hear about them as many times as possible and think about the definition even starting now. But preload is really defined as the force of blood entering the heart, right, from the venous system or the vena cava, or it could be from the pulmonary veins, because you're talking about blood returning to the heart. And then particularly, what is the force of that blood filling up the ventricles? Okay, so it's really the pressure or force of blood in the ventricles, really at the end of diastole when they're filled up. Now, technically, you could probably define that in terms of a force unit or even a volume unit, but I think force is more accurate in preload. And the same thing with afterload. Afterload is sometimes very confusing because it's not, I guess it's not directly related to preload. Afterload, one of the easiest ways to remember this is that after starts with A and so does artery. So afterload is primarily determined by your arteries. Remember, your arteries come right after the blood leaves the heart. If your arteries are really narrow, that means the heart has to produce a very large force to move the blood forward into those arteries, right? Because there's a really strong restriction there. So that's considered the afterload, right? It's the force of blood required, the force required for the heart to move the blood forward into the arteries. That could be measured in terms of an actual force unit, like it could be PSI, it could be something like that, but we don't normally get into the units as much as just the general concept or the abstract idea of just how much force is required, right? You could get into units if you wanted to. Okay, so this is just kind of a reminder of what's happening. I know we've gone through this several times, so I'll probably go a little more quickly here. So what happens, again, this is a syringe with valves, so it's supposed to represent the heart valves, right? So imagine the ventricle is filling with blood, or both ventricles are filling with blood. That would be analogous to the syringe going up, the plunger going up, pulling in blood from the atria, and actually the atria are just kind of the conduit, but the blood is coming from the systemic, well, the systemic circulation, which would be the vena cava, and then also the pulmonary veins. Blood is going in passively. The AV valve is open. Both of them are open. And then you start to push, in this example, you'd push down on the plunger, which would be analogous to the ventricles starting to contract. Temporarily, you have the isovolumetric phase where everything is closed, all the valves are closed. And then you basically push a little more, and it's just enough force to open up the aortic and pulmonic valves. So this is, even though there's only one valve down here, that would really represent both sides of the heart. They'd both be doing the same thing, opening up the semilunar valve, and you should be closing the AV valve should still be closed because it's a one-way valve. And then finally, at the very end, we're running out of volume. The pressure has declined, and then both valves will be shut at that point. And finally, once we start to relieve that plunger force, right, move it back up, which would be like dilating the ventricles, they would start filling up again with blood, right? And that's kind of what we covered, just a little bit of a different way of looking at it. So to define stroke volume, that is the difference between the end diastolic volume and the end systolic volume. I usually ask a question on this, but I hope that you don't memorize it, and rather you look at it and think about what makes sense, right? So this, first of all, the stroke volume is, of course, the volume of blood leaving the heart, particularly the ventricles on each beat. So it has to be the difference between what is in the heart to begin with, which is the end of diastole, and what is in the heart at the end of the contraction, which is the end of systole. So it's always the end diastolic volume minus the end systolic volume. And remember, the end diastolic volume must be the largest, a larger number, right? Because that's after the heart is completely filled with blood. Again, the ventricles, that is. With every beat, the heart pumps about 60% of the blood in its chambers, or 70 milliliters. Again, that stroke volume is only going to be 60% of the end diastolic volume. So there's still about 40% of the blood volume remaining in the ventricles after each contraction. So that's that cardiac reserve. Okay, this stroke volume is related to what's affected by preload, and we're not going to get into that in a lot of detail right now, but we will later. But the amount of blood filling up the heart does actually control the stroke volume, and you'll find that later on. Now, afterload, if the afterload is really, really high, or the arteries are really constricted, the stroke volume might decline because there's too much resistance, right? So those are both related to stroke volume one way or another. Ejection fraction is the percent of blood or fraction of blood leaving the heart on each beat. And that's one way to quantify contractility. So this is really practical because patients with heart failure, they're constantly being assessed for their ejection fraction. So normal ejection fraction would probably be like 60%. 60% would be pretty good. If you're dropping well below 60%, you probably have heart failure, and that means you're probably going to be fatigued and have shortness of breath. So it's a really important term to understand. And that's the ratio of the stroke volume to the end diastolic volume. Or an easier way to say it is how much blood was there to begin with, and then, what percentage of that was removed during the contraction, right? How much blood left the heart, what percent. And that's really all that is. That's all that is, except we express it generally as you can express it as a fraction, which would be like 0.6, or a percent, which would be 60%. Either way, but I think practically the clinicians usually use a percentage. Okay, so increased contractility should cause an increase in the ejection fraction, right? So the stronger your ventricles contract, the higher percent of blood leaving the heart in that case. So the term cardiac output, you're going to see that many, many times in the cardiovascular module. That is the volume pumped by the left ventricle in 1 minute. Okay, so cardiac output also equals the heart rate times the stroke volume. And again, the cardiac output is in milliliters per minute. The heart rate is in beats per minute, and the stroke volume is in milliliters per beat. So hopefully you can look at the units and see how they cancel out, and you get, again, finally get milliliters per minute. So cardiac output is literally the volume of blood getting out of the heart per minute, which is directly related to how much energy your tissues will get, right, from the oxygen and the nutrients in the blood. And then it's directly related to blood pressure, right, because the faster you're moving blood into the systemic circulation, the higher the blood pressure. So interestingly, cardiac output is sometimes something we want to reduce in someone with very high blood pressure. Even though that sounds bad, right, to reduce the amount of blood flowing, it actually can be, right, could be beneficial for someone with really high blood pressure. So you'll see that later on. Factors affecting cardiac output I just mentioned heart rate, but what can regulate that? That's adjusted by the autonomic nervous system or hormones. I will get into those in a little bit of detail later. So again, that would be like epinephrine, norepinephrine, acetylcholine, or hormones that are either directly or indirectly affecting the rate. A lot of them may be indirectly affecting that heart rate, such as thyroid hormone, etc. Stroke volume is adjusted by changing, of course, because these are in the equation, right? You're going to either change end diastolic volume or end systolic volume. And that's primarily influenced by contractility, which is primarily controlled by the autonomic nervous system, right? The more adrenaline or epinephrine you have, or norepinephrine, right, the stronger the contraction. Afterload, which is almost all based on artery diameter, right? The smaller the arteries, right, the more they constrict, then the higher the afterload, and that can reduce stroke volume, right? That could be a bad thing. Preload is also venous return. It's the same thing, and that means how much blood is returning to the heart before each beat, right? So how much blood is getting in the ventricles at the end of diastole. So generally, the more preload, the higher the stroke volume. And then duration of diastole, of course, that means how long is the heart resting before the next beat, right? Of course, the longer it rests, the more it can fill. And then the more it fills, the more preload, generally the higher the stroke volume. So heart rate, even though that's a separate factor, that will influence stroke volume, right? So it's not 100% independent, right? The heart rate and the stroke volume can affect each other, for example. So how do we regulate the heart with the autonomic nervous system? For some reason, this is commonly missed on exams or forgotten. Please remember that the sympathetic nervous system innervates the entire heart, whereas the parasympathetic nervous system it only has a real significant influence on the nodal tissue, and that would be the SA node and the AV node. So if I have excess parasympathetic nervous system activity, I will slow down the heart through suppressing SA nodal cells and AV nodal cells, but I won't have a really strong influence on contractility, which is determined by the muscle and not the nodal tissue. On the other hand, if I have a lot of sympathetic activity, not only will I speed up the heart rate, primarily through the nodal tissue effect, but I'll also increase the force of heart contraction, or the cardiomyocyte contractility. So remember, sympathetic affects everything in the heart, parasympathetic mostly rate. Okay, so that again, that's easy to confuse or forget for some reason, so please do your best to really focus on committing that to memory. So I want to talk about how the autonomic nervous system regulates first pacemaker function. Remember, the pacemaker tissue is the same as the nodal tissue, and it looks like this little kind of hill. It's a little, actually quite different in terms of the action potential shape than the muscle tissue. Pacemaker cells have membrane potentials closer to threshold than those of other cardiac muscle cells. So around negative 60 millivolts, and that number is FYI. Remember, this slope is a spontaneously driven thing. That means the sodium and calcium channels are leaky, and that's making this rate automatic, right? This autorhythmicity or pacemaker potential. But this can be affected or changed with the autonomic nervous system. I'm going to get into how that happens. So first of all, parasympathetic stimulation. Okay, if you have the parasympathetic nervous system innervating the SA and AB node, and that's through acetylcholine, that will extend the repolarization phase and decrease the rate of spontaneous depolarization. That means this slope here, this is the repolarization phase. It'll be longer, right? And it'll just take a longer time to get back down to baseline. You'll also drop lower. The baseline will be lower, so you'll be farther away from the threshold. And then this slope of the spontaneous depolarization phase will also be slower as well. So you're really, it's easy enough to just kind of simplify it and say, well, most of the action potential is suppressed, the slopes are reduced, and the polarization is more pronounced, meaning it gets more negative than normal. So the more negative the intracellular space, the longer it takes to reach the threshold the next time. So not only is the entire action potential longer, it also takes a longer time to re-trigger the same cell for the next action potential. Long story short, parasympathetic nervous system suppresses the nodal tissue, suppresses heart rate because of that. So on the other hand, for now, we could think, yeah, the sympathetic is pretty much opposite. So the sympathetic nervous system causes, right, it's going to release norepinephrine, that shortens repolarization and accelerates the rate of spontaneous depolarization. So that means we drop back down quicker, and we also have a shorter repolarization, or shorter, we'll call it the pacemaker potential here. We're going from baseline to threshold. That's quicker because it's a sharper slope. So again, long story short, sympathetic speeds up the heart rate, primarily because of its effects on the nodal tissue. Some of the major neurotransmitters and hormones that are affecting the heart are going to be epinephrine, norepinephrine, and acetylcholine. They have specific receptors, either adrenergic or cholinergic. So epinephrine, this is for some reason very easy to, I guess it's easy to forget because the name is very similar to norepinephrine, right? It's pretty much, the structure is very similar, except it's got an extra methyl group. So epinephrine, though, is a neurohormone, and that's the main point I was making, is that it's a neurohormone because it's released from the adrenal medulla. That's different from norepinephrine because norepinephrine is a neurotransmitter, mostly released from neurons. Okay, the adrenal medulla can release norepinephrine, but the majority of chemical released from the adrenal medulla, at least adrenergic substance, the majority is epinephrine. Again, epinephrine from the adrenal medulla, norepinephrine from the neurons. So if I say a tissue is innervated by the sympathetic nervous system, you should immediately think norepinephrine. That's what's activating it. Okay, it doesn't mean epinephrine can't, but the nerve itself does not release epinephrine, right? So if epinephrine is going to affect a tissue, that's because the epinephrine is circulating in the blood, and that's the definition of a hormone. It's released by one tissue, travels through the blood, and affects one or more other tissues. Acetylcholine, I'm sorry, I shouldn't have skipped the third bullet. Epinephrine and norepinephrine both activate beta-1 receptors in the heart. That's the heart muscle and nodal cells to stimulate both cell types. So remember, sympathetic affects the entire heart. So the rate will go up and the force of contraction will go up, and that's through beta 1 receptors. And again, about 80% of the beta receptors in the heart are beta 1. Okay, we don't really see a lot of beta 2. You'll see that later on, but those are mostly in the blood vessels. Acetylcholine, again, is the neurotransmitter that activates muscarinic receptors on nodal cells, and that reduces their activity. So one more time, preload versus afterload. Preload is proportional to the amount of ventricular myocardial fiber stretch just before systole. And that looks a little complicated, but all that means is the amount of force stretching the ventricle at the end of diastole, and that's just directly related to the volume of blood, which is also considered the venous return or return of blood to the heart from the systemic circulation. So more venous return equals more preload. Afterload, again, is the pressure that the ventricles must overcome to force open the aortic and pulmonary valves. More arterial resistance means more afterload. Anything that increases systemic or pulmonary arterial pressure can increase afterload. So if you have, again, blood vessel constriction or arterial constriction, more rare, if your blood is viscous, right, thicker, that will raise the resistance or the afterload. And the third thing is turbulence, and we'll learn a lot more about that, those factors in the next lecture. But turbulence is a minor factor that affects that resistance as well. So this is more on preload. There's not much more I wanted to add. Everything you've seen here except for the last bullet, and that it affects the ability of muscle cells to produce tension. And we're going to get into that in more detail in a little bit. But preload related to that means that the more preload you have, the more the muscle stretches, and that is directly related to the contractility. So, in a normal heart, the more you stretch it, the stronger it contracts. So it's almost like a rubber band, but it's a little more complicated than that. The more you stretch it, the stronger the force pushing back. So regarding end diastolic volume and stroke volume, at rest, EDV is low. The myocardium stretches less. Okay, and the stroke volume is low. Okay, again, if you're just sitting or recumbent, lying down, again, the end diastolic volume is low. That means the heart is not filling as much as it could. That means the heart is not stretching as much. That means it's not contracting as hard. And that all makes sense because we don't need to be pumping the maximum amount of blood that we can at rest. With exercise, the end diastolic volume increases. And you're going to learn a lot more about this, but the specific reason why the end diastolic volume increases is because when you're exercising, your skeletal muscles are compressing your veins, and that is forcing the blood to move back to the heart. Myocardium stretches more then with a higher end diastolic volume, and that directly increases the stroke volume. And this leads us to the Frank-Starling principle, a very, very important principle, and it's particularly important because you should understand, at least later on, when you learn this in the cardio module for PT, that that heart failure will make this Frank-Starling principle less effective, or it won't work as well. Okay, so the principle is that as the end diastolic volume increases, the stroke volume increases. Another way of looking at it is as more blood fills up the heart, it stretches it more, that increases the stroke volume. That's the Frank-Starling principle. So what actually does limit how much the heart can stretch? What actually causes that to have a limit? And that's, of course, because of the myocardial connective tissue. That would be the fibroblast, and collagen would hopefully prevent excessive stretching. The cardiac skeleton, which is around the valves, is a non-conductive tissue that's very fibrous that prevents the heart from overstretching. And the pericardial sac if there's a lot of force on that, it will start to resist. Or if the heart is expanding, the pericardial sac will resist with an opposing pressure to prevent that excess expansion. So Starling's law, which is again the Frank-Starling principle, says that the critical factor controlling stroke volume is preload. Again, preload is the degree to which the cardiac muscle cells are stretched before they contract, and you want an optimal length tension relationship for maximal force generation. And all that means is, and you probably remember this from the skeletal muscle lectures, that if you extend the actin and myosin filaments to the right degree, you will strengthen the contraction. If you overextend them, it's you have diminishing returns where your contraction is no longer going to be increased. So there's kind of a sweet spot where you want to have expansion of the muscle, but not too much. Again, the most critical factor causing the stretch of the ventricular walls will be the amount of blood in the ventricles. Okay, and the amount of blood is controlled by the venous return, right? So what is coming from the veins, and then finally, right before it gets into the heart, it's going to be the vena cava or the pulmonary veins. Okay, and the vena cava is where you're getting all the organs other than the lungs, right? All those organs, and the head, neck, arms, everything other than the lungs basically is going to dump into the vena cava, and then the amount of blood returning by that route will determine the preload, which is really the same as saying the end diastolic volume, the amount of blood in the heart at the end of diastole. A slow heart rate or exercise, anything that increases venous return or slows the heart rate generally increases the end diastolic volume. Okay, so that might sound a little confusing, but it means if your heart rate slows down, you'll give it more time to fill, so that'll increase the volume before contraction. However, excuse me, if you're exercising, you'll also increase the end diastolic volume because your skeletal muscle will force more blood to come back to the heart. When you're running and things like that, all your muscles surrounding your veins will compress the veins and force the blood to return to the heart much more quickly and with the higher volume. So it's probably a lot easier to look at it on a graph. The Frank-Starling principle or mechanism is that as ventricular end diastolic volume increases, right, that's pretty much synonymous with preload, right? More volume in the ventricles at the end of diastole means a higher stroke volume or higher amount of blood leaving the heart on each beat. It reaches a plateau. So eventually, increasing this venous return or preload has diminishing returns. So you can't just, again, increase it to any extent you want and expect the stroke volume to rise. Within a healthy range of preload, yes, it will change the stroke volume, right? So your stroke volume should increase. If that doesn't happen, right, if your stroke volume doesn't increase, you probably have heart failure, right? Because your heart is not responding to the excess preload with like a reciprocating increase in or compensatory increase in contractility. So this curve here is in a healthy heart, right? If it were a patient with heart failure, the curve would be more flat, okay, and that would cause a lot of other problems that we'll get into that in the cardio module. Remember, the end systolic volume is the amount of blood that remains in the ventricle at the end of ventricular systole. The three factors that affect the end systolic volume are preload, again, end systolic, right, different from the end diastolic. So the end systolic means how much blood is left in the heart after the contraction or after systole. Preload will determine that because the higher the preload, the higher the stroke volume, and that can affect the amount of blood remaining in the heart, right? Because the more you're pushing out, the less remaining in the heart. Contractility, that's the force produced during contraction at any given preload. Well, contractility can rise specifically when you have epinephrine and norepinephrine being released. That will boost your contractility. So just assume your preload is stable or consistent, and all of a sudden you have extra adrenaline. That will boost your contractility and boost your stroke volume, which should lower your end systolic volume, right? You should have more blood leaving the heart if your stroke volume is higher and your contractility is higher. Afterload is going to make it harder for the heart to pump blood forward, right? So that may increase your end systolic volume. Okay, so most of these things you could simply think of, hopefully just logically, right? Just think, okay, if the afterload is high, meaning the arteries are constricted, the heart's going to have trouble getting blood out. So I would think that after the beat, the heartbeat or contraction, maybe more blood is left in there than normally would be left in the heart, in the ventricles. Okay, so a lot of these things are, I think, somewhat intuitive if you just understand what they mean, right? And then what makes the most sense. So again, how does the autonomic activity affect contractility? So the sympathetic nervous system, again, primarily releases norepinephrine in the neurons, and then epinephrine from the adrenal medulla. Okay, that causes ventricles to contract with more force, and that's to that beta-1 receptor, and that increases the ejection fraction, and again decreases the end systolic volume. So this is kind of, again, it's the same thing, the Frank Starling principle, but now instead of saying what if we have heart failure, now I'm saying, well, what if we still have a healthy heart, but we're starting to exercise, or imagine someone just gave you an EpiPen, right? You had to inject an EpiPen, which is epinephrine, right? That would shift the entire, again, end diastolic volume, stroke volume curve, right? It would shift that curve higher. So you have a higher stroke volume for any given end diastolic volume, right? So you're making the heart have a higher cardiac output for any given preload, basically any given preload there. So also during sympathetic stimulation, the force generated by the ventricles will be stronger, but it will decline faster, meaning you're going to go back to resting or diastole quicker, right? So it's a stronger contraction, but a faster relaxation, and that's all due to the beta-1 receptor. And quite a while ago in the lecture, we talked about phosphorylation events, and all the phosphorylations that occur are going to be causing this. So that would mean phospholamban, the ryanodine receptor, the L-type calcium channel, all that together would make this happen, right? Faster and stronger, but then a faster relaxation. Afterload is regulated by anything that restricts arteriolar or just arterial blood flow. It's really the same thing, arteriolar or arterial. The subtle difference is that the arterioles are small, and just arteries is a more general term for anything leaving the heart. So as the afterload increases, the stroke volume decreases. And I already mentioned that, and hopefully you could just think about it from a logical perspective. So again, there's more resistance, there's more restraint preventing that blood from leaving the heart when you constrict the arteries, and that makes it harder to get the blood out of the heart. So it means there's again, a lower stroke volume, a lower volume per beat. So to summarize the control of cardiac output, I have one slide here on heart rate control factors, and then a slide on stroke volume control factors, and then a summary slide of stroke volume, and then at the very end, combining everything together, heart rate, stroke volume, and cardiac output. So heart rate control factors would be the autonomic nervous system, sympathetic and parasympathetic. You should know which one does what. Circulating hormones is going to be less important, at least for this lecture. Venous return or preload, and then resistance created by the arteries or afterload. Okay, so um, I actually haven't spent much time talking about how preload affects rate. I talked about how it affects the contractility, but by the way, so preload increasing, so when blood return to the heart increases, that actually stretches the atria, and that actually does increase the heart rate. So again, it's the first time I'm mentioning that, and it's not a critical point that I want you to know, but it is true that, again, atrial stretch would cause a reflex response to increase the heart rate. And then resistance created by the arteries or afterload, that would actually have a pretty minor effect on heart rate. So that's not something I would worry about too much in terms of focusing on. Stroke volume control factors would be um, really end-diastolic volume and end-systolic volume. End-diastolic volume is based on how long you give the heart to fill, and then the rate of venous returns, or how much blood and what volume of blood per unit time is returning to the heart. And then end-systolic volume is affected by preload, contractility, and afterload. Okay, so this is the summary of the stroke volume factors. And I won't go over the entire slide here. Actually, I won't go over any of this again on the slide because you've really had all of this. And what I want you to do is use this as a tool for studying, possibly try to do it from scratch, right? Start with a blank sheet, try to do this flow chart, or kind of work with each other. And I would encourage you to leave some of it blank and see if you can fill it in. Okay, so the ultimate goal of this is to be able to understand, again, the main factors affecting stroke volume, which would be EDV and ESV, but what are the main factors affecting those two things, right? So breaking it down smaller and smaller into all the inputs into these two factors. So I have this slide and then a final summary slide. This is cardiac reserve, and I alluded to this a couple of times. And the whole point is that you normally at rest, right, you're not at your maximum cardiac output. So cardiac reserve is the difference between resting and maximal cardiac output. So cardiac output during rest is actually, as you can see here, is between maybe 5 and 7.5 liters per minute. Okay, which is still a lot. If you think about it, a half a liter or 500 milliliters is the size of a disposable water bottle. Again, that's only half of a liter. So 7 liters is a lot, but that's your resting cardiac output per minute. During heavy exercise, you can get up to 20 to 30. Okay, if you're a trained athlete, maybe up to 40, which is absolutely amazing. So 40 liters per minute. Remember, there's a little less than 4 liters per gallon, so that would be close to 10 gallons per minute, which is amazing. If you have heart failure, that can drop below, of course, below your resting cardiac output. So finally, at the end, this is really all the main factors affecting cardiac output, right? And cardiac output is so important, and we're focusing on it because that determines the amount of energy, like I said, being delivered to your organs, the amount of oxygen delivered to your organs in your brain, and really that's the major factor affecting your blood pressure as well. One of the main factors. So cardiac output's affected by heart rate and stroke volume, and we just talked about what influences stroke volume, so you should know those things. What influences heart rate? We talked about those. Hormones, the major one I want you to know is the autonomic nervous system, sympathetic and parasympathetic. And the atrial reflex I briefly discussed on a few slides ago. And that's when you stretch the atria with more preload, you have a natural increase in your heart rate as a reflex response. This concludes the lecture on the heart itself and the factors affecting it. The next lecture is going to be on the blood vessels. It'll actually be a little bit more extensive. It's going to be on arteries, veins, capillaries, what affects artery diameter, so how that's regulated, how the veins are structurally different from the arteries. And then when we get into capillaries, it'll be a discussion of the factors that influence fluid release from the capillaries and then fluid recall back into the capillaries, as well as the nutrients and oxygen flow. And then that will pretty much conclude the cardiovascular system.